Morning, everyone. Welcome to the Adults and Health Committee meeting of the 7th of March 2024. In terms of my chair's announcements, a couple of things at the start. For completely separate and different reasons, both myself and Vice Chair Councillor Van der Ven were away at the last meeting. And I'm told it went very, very well in her absence. So you can form whatever conclusion you want from that. But I would want to place on record my deep thanks to Councillor Boulat, who chaired the meeting on my behalf and did so excellently. Thank you very much, Councillor Boulat, but also to Councillor Slatter, who is, she is with us, to Councillor Slatter, who stood in as acting Vice Chair on that day. So thank you very, very much to you for all of that. And the second thing I want to say in opening is, although she's not here today, I want to just say a few remarks about Jyoti Attry, our Director of Public Health, who's announced that she's moving on with great sadness from our part, but she's going to be present at the Health and Wellbeing Board that Councillor Van der Ven chairs on the 22nd of March, and that will give us as members a chance to pay proper tribute in her presence. But as the committee was meeting today, I just wanted to place on record my and our thanks to Jyoti for the excellent work that she's done as Director of Public Health, coming in at the end of the COVID period and managing that expertly. I think teaching us all really important lessons about public health management, about health in all policies, and helping us to deliver those policies, and also being very influential with the creation of the integrated care system and really speaking up for us as an authority and for public health within that. And I'm extraordinarily grateful for what she's done. I'm also extraordinarily grateful to Val Thomas on my left, who Jyoti, for completely personal reasons today, isn't able to be with us. But Val is going to be stepping in and presenting on her behalf today. And thank you very much, Val, for that as well. My other introductory remarks are the usual ones, that we allow filming and photography. Feel free to take pictures and use social media during the meeting, although not in a way that interrupts the proceedings in any way. And please, everybody here, put your mobile phones to silent or to vibrate. We are being live streamed, and a recording of the meeting will be put on the council's website. If you wish to speak, do the usual, raise your hand, and Councillor Van der Ven will be helping me to make sure we don't miss anyone. Apologies in advance if I do. I won't be deliberate. And also, in accordance with our constitution, after 2 hours maximum, I'll seek to adjourn the meeting to enable a comfort break. We don't expect a fire alarm today. So if an alarm sounds, I will adjourn the meeting and we'll all leave through the fire escape, which is through those doors to my left, next to the kitchen. You go down the external stairs to the car park and assembly point. Those are my introductory remarks. I move on now to item 1, which is apologies for absence. Tamar, please.
Apologies received from Councillor Anne Hay and Councillor Chris Bowden.
Thank you. Do we have any substitutes?
No substitute.
No. Okay. Does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interest? Please, Councillor Daunton.
Yes, we have under item 4, the Section 75 agreement. I'm a county appointed governor on CPFT and they're a partner in the agreement.
Thank you. Anyone else? Thank you very much for that. We now are asked to approve the minutes of the meeting of the 25th of January 2024 as an accurate record. They're found on pages, and I haven't got that in front of me. So could you just tell me the page numbers that the minutes are on? Okay, I found it. The minutes are on pages 5 to 24. Thank you so much. It was there and I mistook it, sorry. Does any committee member want to raise any question or point on the accuracy of the minutes? No, so I will take them as carried unanimously. I will now sign them. And I've got a hand, which is Councillor, Councillor Black, please.
Yeah, Chair, could I just ask, at page 6 of the minutes, the third paragraph, the Executive Director was going to give us a written update to the committee about the workforce position for individuals affected by the closure of Beaumont Healthcare Limited. And there was an update on the number of individuals that have been supported by the council to find alternative roles. I believe we took some of them on ourselves, maybe. I'd quite like to know if there's any more fallout from the withdrawal of Beaumont, that everything's going okay with the providing the service, and that if there's any other problems on the horizon of a similar nature. Thanks.
Just before I bring Patrick in, I think Susan, Councillor Van der Ven wanted to make a short comment.
Thanks. I was actually going to raise this on the next item, the action log, because there's a good update there on page 5. But you're going to.
I was going to say it's in the action log.
As it's been raised, let's deal with the substantive issue now. Patrick Warren Hicks, please.
Yeah, thanks, Chair. So it's in the action log. We've updated in the action log because that was part of last time's committee's actions. So there's a detail in there, but we can talk further once we get to the action log if you like.
I think as it's been raised, should we just deal with it now?
Yeah, so the detail is in the action log, but we supported a significant number of those people who were at risk of redundancy, and we've supported them to move into employment, and we've continued to support them. They've not just come into the local authority, they've gone into the NHS and elsewhere.
I think Mike was interested in numbers and okay. Shall I give you a few minutes to just reflect on that, and we'll come back to it under the action log? Okay, fine. I'm just looking at my list. Sorry, I'm not quite up to speed. I'm getting there. Give me a moment.
Yeah, sorry, Chair.
Just give me a second, because I'm just needing to relocate where I am in the order so I don't get anything wrong. So the action log is the next item, is pages 17 to 23. And I'm told to inform you that action 2 to 8 was circulated to the committee on the 5th of March. Councillor Black first, if you want to come back, and then hopefully you've had time to look at it. You do Councillor Black first, though.
Yeah, I was just going to say, it's at page 21, isn't it, the action log, where it says, I just wondered how many had actually been taken on by the council itself. And as I say, at this stage, seems to be the only point on our agenda where we can perhaps take stock of whether we're at danger of having similar problems in the near future. But yeah, how many have actually been taken on by the council?
Okay, so 2 questions there, Patrick.
Yeah, so I don't have the detail of the numbers that have been taken on by the council, but as the paper says, 90 of the 120 staff found alternative employment. 5 of those 120 returned, so 95 in total. It was left then with 25 people. They decided not to seek new employment at this time, and that time has now passed. We worked significantly with the unions around that, just to support those staff who were at risk. I would remind committee again that this was a private company that had employed these and brought individuals over from overseas. So we had no real obligation. What we wanted to do is maintain and ensure that we got sufficient resources that wanted to stay, could stay, and we supported them to be employed within the adult social care market across the county. But those individuals have taken decisions to go elsewhere, some to other employment, but it wasn't within our gift to help them to do any more. I think we've done sufficient in terms of supporting them elsewhere. And in fact, the union actually contacted us to recognise the significant amount of work that we did do with those people that were at risk.
Yeah, I read the letter from the trade union, which commended the council for the work we've done to help the workers, and I was really pleased to see that, I have to say. Councillor Seif.
Thank you, Chair. Good to see you back. It is a matters arising on the minutes, although I suppose it's an item that could have been put onto the action log. I don't think it is there. And page 7 on the minutes, on the matters that I raised last time about risks, and in particular, well, I think it's got a name, which I didn't know that, right care, right person. There were work was being done in partnership with the police. I just wonder whether there have been any developments on that and whether that could be reported in the action log in future. Thank you.
We're happy to place it on to report it in the future, and if we feel it is a significant risk, then it would be reported within our risk register. So there are 3 phases around right care, right person. The first one is people at risk in the community, which is the phase 1 that's been implemented, and we continue to track that. Any actions or any issues arising as such. Fortunate that we're able to report at this moment there hasn't been anything that's arisen. The second phase is our phase 2, which is around people who go absent without leave from hospital-based care. So that's a much more of a focus for the police and the NHS. Obviously, those people who go absent, they return into communities. So adult social care and district partners are also concerned about that. That hasn't been implemented yet, and the date has been moved back, and there's a recommended date of implementation of May this year. But that's subject to a lot of work to be done to ensure that safety and risks are considered. And then phase 3 is around section 136, which is a specific part of the Mental Health Act and about secure accommodation for people during a period of crisis. And again, that process is again looking at implementation in May, but again, subject to risk and further conversations with the police and our NHS partners as well. So phase 1 has been implemented, phase 2 and 3 is yet to be done, and there are still some significant concerns that are being discussed within the partners before we implement that. Any risk that we consider to be appropriate for adult social care will be reported within our risk register or within the corporate risk if we feel that there's such a level that needs to be reported within the corporate risk. I'm more than happy to bring updates as that progresses.
Can I just add that, I mean, there will be financial implications of this. I mean, we haven't, so presumably that will be, if there are risks, they will be quantified as well.
There are some financial risks, but our concerns are the risk to the individual and to communities if partners are taking a different approach to particular cases which would normally have followed a particular track.
Okay, and Councillor Seif asked if that could be added to the action log for next time so we can have further updates. Thank you very much. And that, anything else on the action log from any member? No, the action log is therefore noted. We have no petitions or public questions under item 3, so we move directly to item 4, which is the Occupational Therapy Section 75 agreement. It's on pages 25 to 98 of the agenda pack, and Diana McKay, Commissioning Manager, joins us to present the report.
Thank you, Chair. Hello, committee. This paper asks for approval to enter into a new Section 75 agreement with Cambridgeshire and Peterborough NHS Foundation Trust, CPFT, for the provision of community occupational therapy services for adults and older people. This will continue to be a public sector partnership and is not a commercial tender process. And having a new agreement will mean that the service can continue to provide a sustainable and a high quality integrated service to the people of Cambridgeshire, ensuring that people remain as independent as possible in the home of their choice. The committee paper includes 2 case studies in the appendix, which are typical examples of the joined-up approach that this service is able to offer through its wholly integrated health and social care delivery model. The integrated service commenced in 2003. It was driven by a need to improve the customer journey, deliver better outcomes for people, and cut the time that people had to wait for an assessment. The average waiting time for assessment is currently 6 weeks based on January's figures, which is an update to the 7-week figure stated in the paper. In the majority of cases, one practitioner can support people through their health and social care OT journey and avoid handoffs between health and social care. The service works very closely with the district councils as well and the home improvement agencies. And this is in relation to the assessment and recommendations for major housing adaptations as part of the Disabled Facilities Grant process. In 2022, an independent review of the service was commissioned, which focused on sustainability and delivery, and the recommendations from that review has informed the new agreement, including a rebaselining of the budget, uplifting it from just over 1.8 million to just over 2 million annual budget. The new agreement includes some new key developments and has flexibility built into it so that it can be varied if necessary. For example, there's a reference in the paper to the possibility of needing additional OT input for the discharge planning and post-discharge process. And there's a comprehensive governance process, which includes a monthly performance board where the County Council meet with CPFT and review performance against a number of key performance indicators. But outside the formal meetings, there is regular liaison with CPFT and a very positive working relationship. It's recommended that the new contract term is 3 + 1 + 1, which gives a total 5-year contract value of just under 10.2 million. So I was going to stop there, but I'm more than happy to take questions.
Thank you very much. Councillor Daunton, I've seen first.
Yes, thank you very much, and thank you for the paper and really clear paper, and it's really good to have that positive response from on the working with CPFT. You mentioned, and it's at 2.2 on page 26, the independent review, and that seemed to be instrumental in moving forward with the new contract. Could you just tell us a little bit more about the review, what it covered, and why it was so positive?
I'm going to take 2 or 3 questions at a time, Diana, if that's okay. Yeah.
I didn't catch that.
Councillor Boulat next.
Thank you, Chair. I wanted to ask around the waiting time. So on page 37, I think it's number 3 at the bottom, it does state that the average waiting times were 4 weeks pre-pandemic, and now we're looking at 6 weeks because, of course, demand has increased following that period. So I'm just trying to figure out if the demand actually increased by more than half, or whether there are other factors that contribute towards the waiting time in addition to demand. Thank you.
One more, then we'll have some answers. Great. Councillor Wilson, please.
Thank you. This is something which I definitely support, having been a CPFT governor previously. Could you just remind us, will CPFT sign up this time, having done all the extra work that you've done? And how will the additional costs be negotiated year on year, the annual uplifts that are referred to? Thank you.
They were very clever questions, and it should be said that CPFT negotiated the previous contract with us and then never signed it. And so that's a very pertinent question indeed. We've got some other members, but I'll invite Diana to come back now for the ones you've heard.
Okay, thanks very much. So first of all, regarding the review that was undertaken, we commissioned the review from a company called SHA Disability, which is a therapy-led consultancy service. They were we felt it was important to have a therapy-led consultancy because of the quite specific nature of the service. They were very thorough. They looked at all aspects of the service. right, the whole pathway from referral, assessment, the individuals involved in the OT interventions. They spoke to service users, to practitioners and to colleagues within the council. It was very, very good piece of work, and had a extensive report and recommendations. And I think one of the appendices lays out some of the things that are now being done as a result of their recommendations. In relation to the waiting times, there are a number of factors that affect waiting times. The service sees quite a fluctuation in demand. I think the paper says that they get around 700 referrals a month. But just to give you an example, in January, that was well over 800. So they do have to respond to fluctuating demand. And also, they have struggled over the last year or so with recruitment. There is a national shortage of occupational therapists. But having said that, they've been really successful in recent months, well, in recent weeks at recruiting some new staff. So it's hope that once they're up to speed, that will have a positive impact on the waiting times. And with regards to CPFT signing up to the agreement, CPFT have been very heavily involved in drawing up this agreement right from day one since the review completed. So we've liaised with their commissioning and contract manager, and Pathfinder Legal have been involved in drawing up the agreement as well. And they have indicated that they will be signing up to the agreement.
Just to say, in terms of the uplift, then rather than a negotiation, the agreement is that the annual uplift would be linked to the NHS offer for their uplift. So we should have a clear process and a figure that comes through and gets agreed quite early.
So if we agree it today, Diana, when will they sign by?
Well, the agreement should be ready to go for April the 1st. So we will be looking for sign off in the next few weeks.
Okay, thanks. Next one is Councillor Van der Ven.
Thank you. Yeah, thank you for the paper. And it's obviously a really important service that some of us as local councillors interact with a little bit through our constituents. So my first question is about the single point of contact, and are you confident that that is clear and works well, that it's understood by those who need an entry way into the system? And then the other one is about rising demand and capacity to meet that demand. I guess you've sort of reflected on that just now, talking about recruitment, but that story will go on. And I wondered if you wanted to say something more about that. Thanks.
Thank you. Councillor Sieff, please.
Thank you very much. I understand that the financial contributions have been calculated on the basis of the previous contribution and uplifted in the way that you've described. But I don't have, and perhaps councillors who were here at the time know how that is comprised. So I'm going to ask you a very simple question of clarification. I mean, is this contribution principally and only in connection with the staff that will be required for the service, and in connection with demand, which may be very difficult to forecast, I should think, is there any equipment involved in this contribution? If it's not, presumably it's coming from NHS, and can we be sure that that any equipment that will be required will be met? I mean, you've given us 2 case studies, which are very comprehensive and heartwarming, that the work that has been done on them, but they both involve very extensive pieces of equipment and house habilitation, which would be very, very expensive. So if we have more priority 3 cases, is our financial contribution and the contribution of the partner going to be able to cover them? Thank you.
Thank you. No, the members, so a couple of comments from myself. One is I'm very supportive of this. It must be right to try and have a seamless service. What I would say is that the governance arrangements are so damn complicated. The idea that we can effectively scrutinise them in this committee, I'm not sure we can, but we trust you that they're right. But sometimes the level of complication, I think many people in the public would say, if you have to have that amount of complication in your management arrangements, isn't it better just to do it yourself? But I wouldn't agree with that argument. I want a joint service, but I just draw to attention the whether having that level of detail in the management arrangements actually makes CPFT more accountable or not, or just buries us all in bureaucracy. I worry about that. At its heart, this is about occupational therapy services, and it's my view that OTs, together with reablement, are some of the best things we do that actually improve people's quality of life. I'm not saying the other things we do aren't also very, very important, but these basic frontline services, I think, are so valuable to people and actually make a huge difference. And I know that there's a nearly £250,000 extra in the uplift that we're putting in, and I'm proud of that, and it'll mean we'll provide a better service in future. So I'm really delighted to hear that. I'm pleased that the members have talked about waiting times, because Councillor Bird, former member of this committee, was regularly asking questions about waiting times. And I think it is important that officers understand that this is an issue of deep concern to members. The service is only good as how long we have to wait for it. And so I hear the answers, so I'm not asking you to answer again, but if you just note the fact that we want you to be very, very vigilant about that in terms of the period going ahead. Those are my comments, but Councillor Slatter has just slipped in under the fence.
Well, I was waiting to see if my question had already been asked, in which case I wouldn't have wanted to ask it again. I'm going to bang on against that, this wonderful document yet again. I know there's a new one coming out, and I'm sure your fingerprints are all over this. I hope so. But for many people, this almost avoids a waiting list. That's why I wanted to bring it in. But at the moment, it doesn't work insofar as you're saying the website, website doesn't actually link in the way you think it does yet. Let's hope that catches up. But there is so much information in here. My only experience in terms of, I had a self-funding mother, but I was deeply suspicious of salespeople, telling her she needed something and, and everybody wanting the best. Now, the very fact that we can recommend somebody is good. And I just want to be sure that this is where we recommend it through. So Safe and Well and Ask Sarah, for example. You're nodding. That's probably enough for me, Chair.
Yeah,
but let's have the paper version, please, because this is what we can take into people's homes or even just get dropped through the letterbox. It's so good, and it does save the waiting lists for a lot of this stuff. Oh, one more thing. I love the single-handed mention, because so much better care for single-handed, and that's often a member of the family. So thank you for not going double-handed all the time. Thank you.
No apology necessary. But a couple of things, we could hear you, but you were a little faint. So next time you speak, can you make the microphone a bit closer to your mouth? And secondly, for the people watching online and for the recording, do you mind just saying what the publication is, just so that they'll know what you're talking about?
I would be delighted. Thank you for that. Yes, here we are, folks. So I'll look at the camera. It's the Cambridgeshire Guide to Independent Living, only it's a 2024 version we're waiting for, but available in all good libraries.
There's no pecuniary interest. This is all in the public interest. Diana.
Thank you very much. I think the first question then was around the single point of contact. The majority of the referrals to the service do come via the County Council's contact centre, and they do a level of screening to ensure that the referral meets the criteria for passing on to the CPFT service, but we do also have OTs who work within the county council for our adult early help service. So if it's something that the contact centre feel can be dealt with really quickly by adult early help service, then it can be signposted in that direction as well. The service will also get referrals directly from colleagues. So, for example, physiotherapists working in CPFT can make a direct referral to OT. But the majority, in terms of from members of the public and from carers, family carers, etc., they come through the contact centre. In terms of rising demand, I think I talked a little bit about that earlier, but something that it would be just good to reiterate in relation to demand is that CPFT have done a lot of work in the last 6 months around what they call the enhanced triage process. So triage is the point at which they get the referral and they contact the person well, when I say straight away, within 2 days, and they have a conversation with the person. And if there are needs that they feel they can meet fairly quickly, they will deal with those straight away, so that it means people aren't on the waiting list waiting for really straightforward, simple things that could be done. They're only on the waiting list for slightly longer term interventions. So that really helps with managing the demand as well. And if I just link that to the comments about the Cambridgeshire Guide to Independent Living, which mentions the NRS Safe and Well service. NRS Healthcare are the provider of our community equipment service. And part of the contract with NRS is that they have to offer a self-help solution for people who want to purchase their own equipment but want some advice as to the best thing to purchase. So NRS Safe and Well is a website, it's a portal that people can log into, and they can enter the difficulties they're having with activities at home, and through a set of algorithms that sit in the background, it can work out what might help them in terms of a piece of equipment, and also it tells them where they might be able to purchase this piece of equipment from. And that could be one of the mobility stores around Cambridgeshire. There's various mobility stores in most of our market towns and in Cambridge, or whether it might be also be available online. So that helps with the self-funders and is one of the things that helps to manage the waiting list as well. In terms of the budget, yes, the vast majority of our contribution is in relation to staffing. In relation to equipment, that is in a separate budget. So we have a separate pooled budget with the ICB for the community equipment service, which is operated, as I just said, by NRS Healthcare. So the occupational therapists that work in CPFT are what we call prescribers. So they are the ones that will carry out the assessment, but when they prescribe the equipment, they're prescribing it from the community equipment service. Okay, so the budget for this particular service doesn't have to include equipment. Other question, I think, unless I'm missing one, was around the governance process, which it doesn't feel that complicated when you're in it, I have to say. It's as I said when I presented the paper, it's we have a really good relationship with CPFT. The meetings are regular, and they present us with a very comprehensive performance report each month with 18-20 slides on, but we've sort of got used to the format of that over the years, and it's a brilliant record of the work that they're doing, and I'm happy to share one of those full reports if anyone would like to see what we get from CPFT.
Okay, so the recommendations that we've got are A, that we agree the new budget of £2,039,000. B, that we enter into a new and refreshed Section 75 agreement to deliver the OT service for a contract term of 3 years +1 and that the total contract value is £10,193,000, and that we delegate authority for awarding and executing the contract for the provision of the service starting on the 1st of April and its extension periods to the Executive Director, Adults Health and Commissioning, in consultation with the Chair and Vice Chair of the committee. Is there any opposition on this? I'm looking on all sides of the table, so can I take it as unanimously agreed? I'm seeing nods from everywhere. Thank you very, very much. And can we just add for the minutes that we've been told that we expect this to be signed by the 1st of April, and if the Chair and Vice Chair could be told when that's happened, that would be great. Thank you very much indeed.
Thank you.
We now move to item 5, pages 99 to 106, the procurement of diagnostic for hospital discharge arrangements. And Will Patton, Service Director Commissioning, will present the report, please.
Thank you, Chair. Good morning, everybody. So this paper is asking for approval to procure some external resources to undertake a full diagnostic of
Again, could you put the microphone just a bit closer to your mouth? Sorry to interrupt, but
Is that better?
just a little bit low. Yeah.
Yeah. I've got a nasty echo in this corner, so I can hear myself twice. It's very... So the paper's asking approval to procure some external resources to undertake a full diagnostic of our hospital discharge arrangements. It's a very significant piece of work and a very significant investment, and is key actually to deliver our savings for next financial year for FY 24-25, along with improving outcomes. And the scope of the work will include not only looking at process, but also and specifically the local authority response. So to put that in a different way, we want to get a much better insight into the effectiveness of our discharge processes, how we work with partners, people's experiences, but also we need to understand where the gaps are and what we can do about those. So, for example, we talk about promoting people's independence. Where are the opportunities for us to improve our performance in that area? We talk about the community offer, which incidentally will link directly into the Care Together work in terms of developing more community-based responses to help people remain at home. We'll look at how we can further improve how we work with the voluntary sector and how we can take a more tailored approach with our commissioning of services to meet specific needs in the community, with a much stronger emphasis on prevention and early intervention. The work would be funded by using monies that have been allocated through the Just Transition Fund of up to 500,000 and supports delivery of the savings of 1.2 million reoccurring, which were approved at full council on the 13th of February.
Important item. Councillor Wilson first, then Councillor Steve. Councillor Wilson.
Thank you, Chair. Yesterday, I think the Chancellor announced that local authorities should be reducing the amount on that they spend on consultants. Although I agree that option 3 makes most sense, it does include £500,000 on consultants. Would you care to comment on that?
The Conservative members would be very pleased to see the Liberal Democrats quoting the Conservative Chancellor from yesterday. But there's a serious question absolutely within that. Councillor Steve.
Thank you, Chair. £500,000 is a heck of a consultancy fee for something that intuitively, at any rate, I've got a feeling that people already know. And if we don't know it here, we know it from either practical experience by talking to OT people and nurses and so forth, or other counties who are offering OT services. I suppose my question is, I mean, obviously the objectives that you've outlined are very worthy and you need that information. But first of all, I wonder whether this is going to be a consultancy commissioned in one single phase, because I rather suspect you could probably do an initial survey of other counties fairly cheaply and find out what their experience is in each of those areas. And there must be, I don't know, best practice already written up. Are we not following it, which is a different matter? And if you're trying to find that out, maybe that's another area to be looked at. But I just wonder why it is as expensive as it is going to be. I agree that we do need to make the savings, but of course, and the savings will be year on year rather than just once off. But it's quite an investment, and we cannot be sure that we will achieve those savings. So I guess I'm asking, have you considered the other options? But certainly the consultancy should, I think, be commissioned in distinct phases rather than the commitment in one fell swoop.
I'm doing it in rounds again. So in this round, last one is Councillor Van der Ven, please.
Thanks. So if I understand it, assessing in the ward doesn't give us a picture of a really good understanding of what that person's needs are. And we don't understand well enough how we can link up to services in the community. And you mentioned Care Together, and I can see that fitting into the puzzle. And presumably, even though our discharge figures are good, this concern is partly also around avoiding readmissions, but please correct me if I'm wrong. So we are a system with the NHS, and this is clearly health and social care. So why are we not doing this piece of work together with the NHS? Thanks.
Will Patton, please.
Thank you. So we absolutely acknowledge it's a lot of money. It is up to 500,000. But I think it's also important to acknowledge that it is a very significant piece of work that requires, from an officer perspective, skills that we just don't have. We don't have necessarily the forensic skills to be able to undertake the work, and hence the approach of using specialists in this field on a kind of one-off basis to help inform, like I say, not only how we improve the process, but also our response to delivering, better outcomes for people. So it is a very significant amount of money. It is a significant amount of work. It's quite wide scope. We are expecting a lot from this work. We do talk to other local authorities, and we understand and we benchmark and what have you. I suppose every local authority and its population and its circumstances are different, though. And similarly to Care Together, it's important that we understand those differences and we understand what we need to do to meet the needs in Cambridgeshire. And there are very significant differences in needs and responses in different parts of Cambridgeshire, let alone from one local authority to another. And what this is saying is we really need to get a much better street view, a much better understanding at a local level about what those needs are. But we will continue to talk to and benchmark with other local authorities, of course. But it's one of those things where you don't know what you don't know. In terms of the 500,000, we are planning to go through a competitive process as part of that. And then in terms of assessing in the ward, that isn't always the best place to make an assessment, and this work will certainly look at that. And it will also, in terms of its scope, be looking at how we avoid readmission. So although the paper and the title talks about hospital discharge, it is also concerned with how we can develop our local community offer in a much more targeted and preventative and early intervention way to help reduce the amount of people being admitted into hospital. We have spoken to our partners. It is important that we work with them as part of this work. Certainly, when we've talked to the acutes, they are very keen and want to support the work. And we've also, that's the acute, so NWAFT, for example, and CUH. As far as the ICB is concerned, we've had conversations with them. Those conversations are continuing. There is some interest from the ICB that we focus on, particularly around some of the mental health cohort and the discharge arrangements for people with mental health. And those conversations are continuing, but we think it's important that we, as a local authority, we lead on this work and we look at this work through a local authority lens.
Thank you. Councillor Slatter is next, please.
Thank you. I'm afraid I cannot support this item, and I've heard nothing from Mr. Patton to reassure me at all. The fact that people who wrote the previous report have left the room worries me. I'd have thought it was part of their report and they would be interested in its fate. But that's obvious, they've got other things to do. But to go back to what you're saying, that this will be a one-off contract, time limited, to be completed within the financial year 24-25. That is impossible. To be doing what you're claiming to be able to do, to get better street view at local level, you could spend a year going and talking to the people who are actually experienced in it and run out of time. I find this extraordinary. Indeed, we do not expect our council officers to have the skills to know how to deal with this in every case, but protocols and diagnostics and models, generally speaking, don't address the sort of issues that are dealt with by that booklet I was waving about. And I could not look some people in the eye to say £500,000 of our money is being spent in this way, when we know largely, as Councillor Sifa said, where the problems lie. Health Watch knows where the problems lie. We know where the resources are scarce. It is just extraordinary to me that we think of a diagnostic of hospital discharge arrangements. You make mention of discharge to assess. That takes months. And for somebody to come in and find out where the problems are with discharge to assess, and they would then get anything like as much information rather than just asking the district nurses, I'm baffled. And I mean, Councillor Cowell has personal experience of this. He sees the problems. He could probably write you a diagnostic a lot cheaper. I certainly hope he wouldn't charge so much. So the same price right around. No, seriously. I'd be interested to hear what Councillor Howard was going to ask, because he knows what's going on, and we all know what goes wrong. But to spend £400,000 to somebody else to give us that answer, I don't see the justification. I'm sorry.
Okay, you might want to consider framing an amendment, which could be referring back and just asking if it's to reflect on it, or it might be to ask it in phases, like Councillor Sifa said. But have a think about that. I'm open to what you might say. We'll see. I will make my own contribution. Oh no, I'm seeing Councillor Howell, so I'm going to take Councillor Howell before, and then I'll make some comments.
Thank you, Chairman, and I thank everybody else as well. I have concerns about this, some great concerns. Approximately just under £2,000 a day. That's what this is working out at. And I want to know, if I put my hand up to say yes, what am I going to be getting for £2,000 a day? Could you just bring it alive a bit more, please? Thank you.
Thank you. And Councillor Daunton has asked to speak.
Yes, thank you. I think I'm probably more positive than Councillor Slatter on this. Having heard the benefits which the CPFT Section 75 brought from the independent review from the consultancy, and how that really moved the dial and helped them to move towards the renewal of the contract. And my question really is about the partnership working and the people that you're going to talk to. And Will mentioned mental health discharge. And I just wonder about talking to district councils, because obviously with mental health discharge on many occasions, housing is an issue. And I'd just like to hear you talk about that, please.
Thanks for your contribution. The first thing to say is, and let's be honest about it, for 2 years, when our administration came to power, we've been told that we provide an excellent service, and it's excellent because we have people in the woods. And we've got a new Director of Adult Social Services who's come in and said, actually, this is completely out of line with national practice, and we need to be looking at it. Now, my first response to that is we've brought in a new Director of Adult Social Services precisely to get some fresh eyes and thoughts and experience, and listen to what he's telling us. And he thinks we're well out of line as we exist at the moment, and I think we have to take that seriously. So in principle, I'm very supportive of the direction of travel. I'd want to say that first, although it's interesting that we were told a completely different story for the previous 2 years. And I know the staff, because I've met them, are enthusiastic about the service that's provided at the moment, but you can't blame them because they're providing a good service. And what is clear is that we're very good in comparison with neighbouring councils and our statistical comparators in terms of discharge. And we clearly, we don't want to lose that. And that's why these things are taped. We'll see in 2 years' time that whatever changes that we start making today don't have an unexpected effect. I am worried too if this is too savings driven. Yes, we've agreed, and we must take ownership of what we've agreed on the savings, and this is part of driving those through. But I also believe, when I talk with the officers, that this is going to be a better service in terms of outcomes and protecting people's independence. I think they're motivated to do that. And as long as that is the lead driver of what we're trying to do, then I think as members we should be supporting it. Like everyone else, and like Councillor Van der Ven, I think the ICB should be a joint partner in this. Without saying more, I know we've been open to that and are open to that. We're supposedly one system, and the idea we lead on this, as Will Patton says, I completely agree. In a system, we'll lead on some things, they'll lead on other things. That's completely normal. But they should be a full partner in this, and I agree with what Councillor Van der Ven has said, and it's fair to say that's been communicated both between us and our officers, and between our officers and the ICB. In terms of the level of money, I find this high, I have to say, and we've had some discussion with the officers privately in the run-up to this. My feedback to you, Will, I think you were showing a lot of humility there, which is not unusual for you, and not a bad quality at all. But in my view, there's a lot of expertise and knowledge in our own officers about this, and it's probably a time and capacity issue as well as a knowledge issue that means it's difficult for you to undertake this at the level that you believe, and I note that, and I hear that. But I am listening to what members are saying, that it's a competitive bid, but that, Patrick has already said to me, is a maximum. It doesn't mean that's what we'll spend. You've heard from Councillor Seif a suggestion about perhaps phasing it. And I think that I am asking officers to hear the feedback from members that we are concerned that this is a disproportionate amount of money for a task that we recognise is important and want to support. I don't think I've heard anything that suggests otherwise, but the amount of money seems very high for what our expectation will be. So I will listen carefully to the answers, and I'll ask you first, Will, and then Patrick to comment, or the other way around, whatever you choose between you. And then I'll take a view about what we do in terms of process terms. Is it Patrick first?
Do you want to go first, Will? Just on the
Okay, Will first, then.
what's expected, and then I can cover it.
Will, then Patrick. Will.
Yeah, so I'll just try and summarize the expectation from the work. So it's in two parts. One is looking at the processes. So when we work with our partners and we look at the way in which those processes and we work together in terms of discharging people back into the community, how are they working and what impact are they having on both the individual that's being discharged, but also the effectiveness of those processes, and where can they be improved? And mental health is a really good example of where we believe there are significant improvements. But we need the evidence to see that. And then the second part of the work is around our response. So when you look at our discharge performance, it does look good, but that doesn't mean that we can't and should be doing better. And I suppose as part of the business plan and as part of this work was about our adult services being more ambitious around improving, and when we look at benchmarking, we benchmark well, but we think it's important to be ambitious around promoting independence, having a really strong community offer, which, like I say, is linked into and developed as part of the Care Together work, that we work much better and in a much more aligned way with our voluntary sector, and that we start to tailor our services and our responses to meet very specific individual and community needs, but through a sort of prevention and early intervention lens. So this is as much about doing more and going beyond as it is, just trying to, improve performance a little bit.
Thank you, Will. Patrick.
Yeah, thank you, Chair. So I would draw committee's attention to the section in paragraph 2.3, which highlights that the Department of Health and Social Care published the hospital discharge and community support guidance. Sorry, Chair,
I will bring me back, Councillor Howell, but I think I'm not stopping you speaking, but I do want Patrick to continue. I think it's an important debate we're having here, and I think it follows on from what Will Patterson said. So I'm going to take Patrick first, if I may.
Chair. Which sets out the practical expectations of the D2A models of delivery, and as is in italics, it states that under the discharge to assess model and home first approach to hospital discharges, the vast majority of people are expected to go home following discharge. And so there's two aspects of that which I've found in Cambridgeshire, which are, I wouldn't say concerning, but questioning for me. So one is that we don't apply the D2A guidance, so the home hospital discharge and community support guidance, we don't apply that in Cambridgeshire. And the second bit is that part of that guidance, also within the Care Act 2014, it revokes our need to assess people in hospitals. But in Cambridgeshire, we still assess people in hospital wards and hospital beds. And we know that that's not good outcomes for people, because somebody sat in a hospital bed is not the right place to assess somebody. And yet we still do that in Cambridgeshire. So the performance looks okay. Performance is good, and we're not on anybody's radars for poor performance within hospital discharges. But the detail of why that is are questions that I'm asking myself, both for social care, but also for people's outcomes. And having conversation with some of our community NHS partners and our acute trusts, they are considering further investment in more intermediate care beds, which they don't want to do, but they need to manage the levels of demand and flows out of their hospital better and more effectively. So my question that I'm asking, which is why I think we need this diagnostic, is to understand what happens in the ground, really following the numbers, following people out, and what would be the best pathways. Section 2.4 highlights the 4 pathways that happen coming out of hospital. And I want to be sure that we're maximising pathway 1 and pathway 2 where possible. But to understand the numbers that are coming out, to help us then work with our partners around the different arrangements that we may need to put in place to really maximise outcomes for people and make sure that we're better spending the Cambridgeshire pound more effectively. And that doesn't just mean the local authority, that means the NHS partners and our third sector partners as well.
Councillor Howell.
Thank you, Chairman. Thank you very much. I take on board what has just been said on both occasions, very much indeed. So, and I can see where we're going from this. I still have concerns, and I suppose now it really comes down to the money aspect. And with regards to the money aspect, is 3.5. If you look at 3.5, please, you will see there that we haven't yet got any indication of how much this is going to cost because we haven't procured anybody yet. But I can damn well sure after this meeting, whatever we procure, whoever people, the cost will come in at £500,000. Now, we don't know that. I mean, it could come in at £100,000, but since we've made a decision on £500,000, it's going to come in around there. So I think we put the cart before the horse here, and I can't support this at this current moment. Taking on board what has been said, I think we've gone the wrong way about it. We should get out there, get some tenders in, then they come back here like we normally do. Thank you.
Okay, I need to bring some order to this. I invited Councillor Howell to come back because he had indicated earlier. What I'm going to do is take a final comeback from Patrick, as he indicated, close the debate, and then I'm open to amendments. I'm looking at Councillor Seif, I'm looking at Councillor Slatter, and I'm looking at Councillor Howell. If you want to frame an amendment, you're welcome to, but I have closed the debate. Patrick.
Thank you, Chair. So the reason that the paper includes a figure up to that amount is that from speaking to other councils that have had similar diagnostics done on a system this size, the costs are up to that range. So what we wanted to do is to get committee's approval to go out because we want to make sure the market is responding and we're able to implement this as soon as possible into the new financial year. So we've not plucked a figure out of the air. We've talked to other councils of a similar size of complex system that we work within, and that's the kind of figures that we are working to. The cost may not be up to that figure, and the cost may not be fully borne by the council. We're still having conversations with our partners about that, but that's the position why we've quoted that there, because that's why we understand the market conditions are such for a complex system to do a diagnostic to this level.
So process points, not reopening the debate. Councillor Seif, I think I saw first.
I won't continue the debate, Chair, but I will just say that I am and have for most of my professional career, such as it has been a management consultant, and I can't tell you the number of times that we end up doing.
That sounds like a debating point.
Well, it's not a debating point, but it's leading to my amendment suggestion, which is that, you know, if we know what we know, we should just do it. I don't see why you need to spend consultancy money to do that. So my amendment would be that it should be in phases and that we should do a comparative study before we go into the depth of the detailed study that may be indicated from the comparative study. But if the comparative study is clear, we should just go ahead and implement what seems to be best practice. I haven't given you the words there, I'm sorry.
Okay, I'm going to hear from Councillor Slatter and Councillor Howell if they want to speak, and then we'll have a think. But Councillor Slatter, if she wants to speak.
Yeah, I stand corrected as to the proportion of assessments that are done in hospital and not in the home, because my experience has generally been they try and do a partnership, but they know they can't get the full picture. Now, that was missing from this report. We know what D2A is. We know the advantages of it. We also know that the bed blocking problems are being addressed. That was missing, but it still doesn't really allay my concerns that.
I'm
we're
very
doing
keen
So,
that you move to process, please.
It is to do with the process. I regret that we don't have figures as to where the discharge to assess is not happening and why. If that's part of the diagnostic, fair enough. But it's an awful lot of money.
I hear that. When I've heard each of you.
Is that part of the diagnostic?
Yeah, when I've heard each of you, I'll try and distill what I've heard. Councillor Howell, if you wish to speak.
Chairman, I'm not going to put an amendment. I will be voting against this particular issue.
Okay, the only, sorry, is it, yes, Councillor Wilson, and again, it's not the debate, but the content of any amendment I'm looking for.
Well, I'm going to support it. I'm not going to amend it. I wanted to pick up on something which Richard said. I think he's incorrect in saying we don't normally indicate how much a consultancy or a contract might cost. For the reasons that Patrick has given, officers have worked out what it might cost up to. If we were producing our capital program or our revenue program, we would indicate how much we think each individual topic might cost. And this is exactly the same here. I think it's good use of money and something which we can't do in-house, and therefore I will support it.
Okay, so the only, I take Councillor Slatter's point, but I think that can be dealt with by coming back with more information, and I don't think should be subject to an amendment, but it should be noted and that information should be brought back. So the only proposal here in the table is Councillor Seaves, which is that we would say as a committee that this money should be spent in phases rather than in one contract. Do I see a seconder from that from anyone? I don't, so that falls. I'm now going to put the recommendations to the meeting, which is that we approve the procurement of resources to carry out a full diagnostic of discharge arrangements, including better known best pathways for Cambridge residents, which may include acute hospitals outside of the county boundary, including Peterborough City Hospital. That B, we delegate responsibility for awarding and executing any contracts for the provision of the diagnostic of discharge arrangements to commence after the 1st of April to the Executive Director, Adults Health and Commissioning in consultation with myself and the Vice Chair. And C, a little controversially, but there is no amendment, that the work has an estimated contract value of up to £500,000. As we've had a hot debate, I'm going to take a show of hands. Those in favour of that, please show. Those against, please show. Oh, sorry, I should take abstentions. I apologise. Abstentions, please. So that's 6 in favour, 4 against and 2 abstentions. I don't think it's done any harm at all to have that debate. And I know officers have been listening carefully to our concerns and will reflect on it. So I think I actually commend that debate, because we're here to discuss the difficult issues and not to dodge them. So thank you very much, everyone, for that. And I know Will Patton has to slip out shortly, and thank you very much for him for staying on. We now move to Justine, who's already in place, because she knows how we work. Justine Hartley, item, whatever it is, because it's on the corner of my page, 6, the Finance Monitoring Report, pages 107 to 150. Justine is our Strategic Finance Manager, and sometimes this report gets very late on the agenda. We can't do it justice. So today we've got you nice and early, and we can have a good deep delve into what you've got to tell us. Justine.
Thank you, Chair. Okay, so this is the report for January, and just in summary, the adults position is a forecast underspend now of 3.9 million. That is quite a shift from what we've been reporting previously, and there are 2 key factors feeding into that. Sorry, it's bouncing back at me when I'm too close, so I was sort of stepping back a bit.
It's a common problem we've been having today. I think if you actually move the unit closer, as long as that's not causing so much echo, it's putting your...
Okay.
Thanks.
Yeah, so sorry, so let me just summarise that again. So adults, 3.9 million forecast underspend now at the end of January, and that is quite a shift from the position that we reported in December. There are lots of sort of small shifts in there, but there are two key things. So one is the vacancy factor, and we've talked about this as part of the business planning round, but we look at vacancy factor every quarter, and we've just done Q3, which is why you're seeing this come out now. And we have taken quite a significant chunk of budget away for on a one-off basis in year. It's an in-year adjustment that we do because of staff vacancies and turnover and things like that. So that is now above where we had forecast it to be, which has pushed the underspend up. And the other big thing is about grant funding. Again, we've done a sort of quarterly review. One of the issues that we have always with grant funding is you get this money, you've got to spend it by the 31st of March, you have big plans about what you want to spend it on, and sometimes procurements, etc., take a long time to get through, and we don't manage to spend it all. So we've been looking at the position on grant funding, and there's more grant funding we can apply to sort of contribute towards demand growth and everything else that's been put into the adults budget. So overall, that's what's leading to the position on adults. On public health, a very small forecast underspend of 49,000, making real efforts in public health to keep the underspend down and find alternative methods of delivery where we've got issues with particularly primary care and some of the smoking work where we've got underspends. Val and her team have been pushing to try to find alternative ways to make sure that we still deliver the services and spend up the grant we've got. You've also got within the report the savings tracker. There are some under deliveries, there are some over deliveries against individual lines on that, but it is, I think, a really positive position that at the end of Q3, we're saying across both adults and public health that we expect to deliver savings in full on balance across the sort of entire suite. So that's good. And then you've also got the reserves position and the forecast position for year end. The only other thing I wanted to reflect on quickly was the debt position. So you've got a bit of an update on the debt position as we've discussed here previously. So the debt position has risen again from October to January. And partly we expect that because we are working through financial assessments backlogs, and some of that leads to some increased billing, which then can lead to some increased debt. But as you all know, there's a debt deep dive going on. There's lots of really focused work to try to bring that down. The two key areas are court of protection debt and deceased debt. And court of protection debt was the first area that's been really focused on. So whilst in here it's gone up from the last time you saw it in October, actually October was, it has been coming down since then in terms of court protection. So court protection is moving the right way. Deceased is going up still quite a lot, and that's our next area of focus. So we're sort of chunking up the debt into manageable chunks where we've got similarities of processes and working through those to drive down that debt. So it's not a quick win situation, but it is there is a lot of work going on to try to reduce debt going forwards, and I'm hoping that that's what we'll start to see the next time I bring this back. Happy to take any questions.
Thank you very much. First one is Claire, Councillor, getting back into the trade of things. Councillor Daunton.
Yes, thank you. I'd like to understand a little bit more about the grant funding and the problem of the grant funding. Obviously, there's the short-termism of the grant funding and the fact that you don't know from one year to the next what it's going to be for and how much it's going to be. How is that process managed? Is it that different areas of adults and health have a different approach to applying for grants or putting forward work for grants? What is the issue in terms of grant funding? Thanks.
Again, I'm going to take them in rounds of 2 or 3, depending on how many hands I see. The next one is Councillor Black.
Thank you, Chair. I just wanted to make a comment. It does seem rather concerning that we're £4 million underspent when we are worrying very much about the sort of service that we're delivering. And I'm just wondering quite how worried we should be about this. The most important part of this seems to be At page 134, we're told we've got item 111, underspends from vacant posts were larger than assumed in the budget, forecast to contribute 1.7 million. And I'm assuming that these are posts that are actually quite very much needed to be filled and to do the work that people need to do. So it is a situation that concerns me, and I feel that we really shouldn't be wanting to be in a position where we're getting underspends like this, and indeed that we're underspending by more than we'd actually forecast to as well. So I'm starting to register some concern about that. Thanks.
And as that question's been raised, I'll insert myself and to just add to that. To me, this is easily the most important thing in this report, and that level of underspend, which I believe was referred to in the last meeting. I was absent, but I believe there was some discussion about that in the last meeting. But as I understand it, it's almost entirely due to our difficulties in recruiting. But that clearly then has a huge impact on the service. And I share the concern of Councillor Black, and I would hope others that this is something that we have to do better to address within the absolute maximum of our capabilities. And so I will ask Justine to reply in a second, but also I know Patrick and Councillor van der Velde and myself has discussed this privately, but I think it's quite important to hear from you as well, because I think it's, as I say, easily the most significant issue within this report. Justine Hartley first, please.
So I think all of those issues are intrinsically linked, actually, because we have got significant amounts of money that have come into adult social care through grants. And I'm not talking about small value grants. I'm talking about market sustainability and improvement funding, which is 8.5 million. I'm talking about hospital discharge funding, which is 2.5 million, or something in that region. It's about, so we worked plans across the whole of adult social care about what we were going to spend that on. And some of that has happened and some of it hasn't. Some of it's about putting in posts that we'd really like to put in. But again, if you can't recruit, then you can't necessarily spend that money. What we can do with that money is use it to, and what a lot of councils are doing is using the money to support demand growth that they're seeing across adult social care. Now, the way that Cambridgeshire works, we put in all of our demand funding at the beginning before we knew the levels of some of this money. And that was at the expense of savings having to be made elsewhere in the council, et cetera, et cetera. We've got that money and we can use it in that way. And we have to look at this within the corporate position of the entire organisation. The council has been reporting significant overspends on children's in particular. I think with this position now, the numbers coming down to a more manageable level, but we have been reporting a very significant overspend for the council as a whole. So it's about how we use the grant money to the best advantage, just for adults, but also within the context of the overall council. I'm sure Patrick will agree absolutely that you don't want the vacancy factor to be that high. We set an expected level. We're slightly cautious on that because we don't want it to be that high, but we do find realistically that that's where it gets to. So I don't know whether, Patrick, you want to add anything in terms
of and I think the key, thank you very much, Justine. And I think the key question, Patrick, is not do we want it to be better? Obviously we want it to be better, but what we're doing to make it better.
Thank you, Chair. So just some points on the kind of underspend position. So committee will appreciate this is a significant budget and it's extremely challenging to get it to land at zero at the year end. So whilst 4 million underspend is not a position we would really want to be in, it's a significantly better position than 4 million overspend. So I think an underspend position is the more safer place to be in around both the Adults Health Committee, but also in a corporate position as well. Because you have to appreciate we need to understand the whole corporate position and the need to deliver on a balanced budget within the corporate position without having to use too much of reserves and one-off monies in order to reach that balanced budget. So there have been some corporate actions that we've been taking, one of them around a workforce expenditure panel, which has been managing the recruitment to particular vacancies. And that has had an impact, not significant impact, I would have said, but has had an impact on the way that we vacancy manage. So I think the combination of responsibility towards the corporate position the volatility of the adults' health and commissioning budget overall and our actions within that corporate position has meant that we are now forecasting a £4 million overspend position. I've had conversations with Justine. Whilst we're close to the year end and there are still some movements, I don't think it will change much more towards the end of the year. But there's been some really difficult decisions taken in order to focus on the corporate position as well as try and manage the pressures that we have within our own directorate. On the workforce perspective, we would want to have much more people within our roles. So we wouldn't want the vacancies to be at about 20%, which they currently are. We would want to ensure that we're recruiting more people and we're retaining more people, because the levels of churn and turnover in people leaving means that even if we're recruiting people, we continue to have circa 20% vacancies. And that's where our focus is, because when we have vacancies, we have to use other alternative workforce, so agency or other locum staff to help us to meet the levels of demand, but also it places significant pressures on our existing workforce, those that are employed within the teams to manage and deliver on their performance. And actually the performance report will show that we're doing some really great things with this challenging workforce and this challenging time. So how we're looking at it is we're looking at our whole recruitment and our retention approaches, things that we could do differently, things that we could work with. We're doing some regional benchmarking around our pay and our conditions of service and our terms and conditions to make sure that we're maximising the opportunities for people to come and work in Cambridgeshire, because we really want people to come and work in here. But what we need to understand is the factors around how we can make ourselves more attractive and why people choose to come in Cambridgeshire and people choose not to come to Cambridgeshire. So they're pieces of work that we're doing in order to try and address the vacancy factor that we've got.
Thanks. I've got a number of other members that have already shown, so I won't include anything about that, but I think that answer's been heard. Councillor Wilson was next on the list.
Thank you, Chair. Two things. One, picking up on what Patrick's just said about workforce, I think it would be helpful if we could have a specific session on all the activities that you're doing at a future meeting. Maybe that can be included in the agenda. And secondly, I'm pleased to see that there's an awful lot of activity going on debt. But again, I'm unclear what the responsibility of this committee is versus audit and accounts that Jeff and I sit on versus strategy, resources and performance. And it would be good for us here to be able to see the adult and social care debt management improvement plan and all the activities that are specifically going on to reduce the debt, because debt is extremely high. And although there are a lot of activities going on to try and reduce it, it is still continuing to be high, and we should be having a better idea about what's happening. Thank you.
Thank you. Councillor Van der Ven.
Thank you. I would also support that closer look at workforce and recruitment issues. And I know when we were talking on the action log earlier around Beaumont Healthcare, the work that's gone on that we've seen in understanding where people are going when their situations change has been quite eye-opening. There are a lot of issues around international recruitment, which I don't feel we have a handle on and would be useful also to understand in that context. But what I was going to say on this paper was just to draw attention to the public health aspect, because it is this does also cover public health, and the concern around the current state of primary care, which we rely on to deliver our spend. And the paper, acknowledges the really difficult position that primary care continues to be in. There's a reference to community pharmacies, and I believe in our pharmaceutical needs assessment work, we are aware of increasing pressures on pharmacies, and just wanted to draw that out a little bit and wondered if there was, if you wanted to comment about that. Thanks.
Anyone else? Okay, just add one thing in response to Councillor Wilson on debt, you might remember that I asked for the debt management implementation plan to be subject to member scrutiny, and we were told by the monitoring officer that was the role of the Strategy, Resources and Performance Committee, not ours, so we weren't allowed to. So I went to the Strategy, Resources and Performance Committee and said, why aren't we allowed to scrutinise the plan when it deals with our own committee? And they said, you are, it's a joint responsibility and there's nothing stopping you doing it. So I think our concern should be both what has been said by Justine Hartley and by Councillor Wilson, that we want to deal with high levels of debt, but also that we do so in a sensitive way, because sometimes we're causing problems for some of our service users by late billing, and that's causing real hardship. And I think we need to have a broad view of that and to make sure that the implementation plan fully reflects all the concerns that we have. But as I understand it from what was said at the Strategy, Resources and Performance Committee, we're allowed to do that. So unless we hear a different answer from the officers now, can we get that plan, and can it be subject to future member scrutiny? And no, there was a separate point, but I'll do that in the summing up. We hear from Justine first. Justine, please.
So I think in terms of the debt management plan, I mean, I don't see any reason why it shouldn't be shared. Obviously, it's a joint plan, so it's not as Councillor Howard said, it's across this committee, it's across Strategy and Resources and Audit and Accounts, but it's also across adult social care and across the sort of corporate teams. So it's a very joined up plan. What you'll get in there is actions that are actions to be taken by adult social care, but you'll also get a lot of actions that are taken by that corporate debt team. But I don't see any reason why you can't review that and see what's in there. And there is a lot of very specific work being done that is by that corporate debt team that is about adult social care debt and the particular nature of corporate protection, deceased, etc., etc. So, yeah, I don't know whether Patrick wants to add anything to that.
Just for time reasons, were there any of the other questions you wanted to comment on, Justine? And then I'll bring in Patrick at the end.
No, I don't think there was anything else for me to comment on, because I think Val was going to answer the question about community pharmacies.
Patrick said he's got nothing to add, so a complete answer has been given. But in response to Councillor Venn, Val Thomas, please.
Thank you. Yes, it's been an ongoing challenge with capacity in primary care and delivery of the public health services, and most acutely affected is smoking. It's more of a drain on capacity than the other services. I think there's a shift in how we address smoking, and that reflects the need. Smoking rates have come down considerably from where they were 10, 20 years ago. And we know that the highest need for stop smoking services are in certain population groups, the homeless, drug and alcohol users, people in mental health services. And I think where we are redirecting our efforts are towards those groups where we know they have higher smoking rates. They're more challenging, certainly. And I think this is acknowledged by the additional funding that we are getting, just confirmed last week, in fact, nearly 900k for this coming year to redevelop and reshape stop smoking services. And I think this will be a move away from primary care in terms of stop smoking, principally because the needs are within population groups that don't access primary care. So we need to have that in reach into those areas.
Okay, the only other point, thank you very much, by the way, Val. The only other point from Councillor Wilson's earlier intervention was to ask for the efforts to drive up recruitment and drive down the vacancy rate to be put on a future agenda. And we don't need a formal amendment to do that, do we, Tamar? We can just note it. It's noted already. So all we have to do at this stage is note the finance monitoring report. Everyone happy with that? Okay, we're going to take the break here. Can you be back by 11:45 at the latest, please? 11:45 at the latest. Only you and I can say that to each other. Okay, can you take your seats again, please? Just making sure Councillor Seif is fully comfortable. It's very important. Okay, thanks everyone. We now move directly to item 7, which is the Adults Health and Commissioning Risk Register update. That's on pages 151 to 176 of the agenda. And Patrick Warren Higgs, our Executive Director, is going to present. Patrick.
Chair, I've asked Sarah Byes joined us as our Head of Performance and Strategic Development. Sarah's relatively new in post, started in early January, but Sarah will be presenting the paper and I'm happy to support Sarah.
And my memory is that we have seen you at the committee before, haven't we? It's not your first time. Sarah, you're very warmly welcome at the committee. Sarah, bye.
Thank you very much, Chair. And good afternoon, almost good afternoon, committee. I'm just presenting the report for Adults Health and Commissioning Risk Register. As you are aware, the register contains the main risks across both the operational services and commissioning elements within the Directorate. In line with the Council's risk framework, risks above 16 are escalated within the Council structures for further oversight, and the leadership team reviews all the risks on the register on a regular basis, ensuring that all of the mitigations and triggers that are against each of those risks are reviewed, and that we keep on a good overview of all of the progress against any mitigated actions. The current register overview is provided within the report with an outline of the risk triggers and current mitigations in place. There are 16 risks in total on the register at the moment. One very high risk, which is rated at 15. That's risk number 16 within the register, and that's around the failure of the council to deliver assessments for safeguarding. It's high impact, and there's a number of variables, including funding and demand for those services, but there are multiple mitigations in place to manage the risk where available, and the risk currently remains stable. Of the other risks on the register, there are 12 that are currently rated high and 3 medium risks, which are outlined within the report with risk owners, mitigations and triggers in place against all of those. I'm happy to take any questions against the risk register.
Thanks very much. Comments from members, please. Councillor Howell first.
Thank you, Chairman. If you don't mind, I will concentrate on risk number 16. And I will say on triggers number 1, inability to recruit, train and retain experienced staff. Are we talking about AMPs there? And are we talking about others? And what are we doing to actually see if we can get those staff, and more importantly, retain them? Thank you, Chairman. Oh.
And it may well be, we're doing it in rounds, if it's okay. So if you listen to 2 or 3 and make a note, then I'd be very grateful. But just to inform you, we had quite a long debate just before the break about staffing recruitment issues. So it follows on from an earlier point. Councillor Black, please.
Thank you, Chair. I'm just going to mainly address, I suppose, risks 1, 8 and 15. But what I'd like to do is to compare what we have here with what we have on the next agenda item, the public health risks. There's some sort of read across here, and I'll just refer you to risk E on page 185. And this is the one that says there is a risk that system staffing capacity will be insufficient to implement or maintain commissioned risks. The main problem there is we've got lack of skilled workforce in general within the system, and it's talking about right across with commission services as well. And then we have risk H on page 187, risk of contract failure in our commission services. Risk A on page 182, insufficient resources to maintain staffing level. Now, risk E, the first one I've mentioned, is actually shown as a high risk and likely, is in red. Risk H was very high as a problem and unlikely.
I'm really sorry to interrupt you, Councillor Black. If it's a comparison between the two reports, that's great. But I'm just a bit worried we might be getting into the detail of the later.
Yes,
report.
indeed. Yeah. So what I want to say is specifically, I want to compare these risks. You'll notice that the risk status on the public health report seems to be being ranked as higher. And I'm not sure that my gut feeling is that the risks are higher in public health. It seems to me that we have clear and present dangers in our Commission's services in adults and health. And so that's the point I'd like to make. You know, I'm worried that we have had providers leaving the market, and we've had shocking CQC results in Commission services in public health, you know, where the care homes and domiciliary care services are not getting the results that we'd want. So, you know, it worries me a little bit about this risk register, and my gut feeling is that our biggest risk of failing to deliver and a sort of system failure is within our Commission services in adults and health. Thanks.
Okay, so first of all, just say I will bring you back when it comes to the public health risk register report if you wanted to follow through some of those issues more in detail there. But the question that I'm hearing to Sarah is, when the councillor makes a comparison between two reports, it looks like one is underscored, and of course all committees and all service areas of the council have risk registers, so that could be public health, but it could easily be another area as well. So it's a very legitimate question under this. As that was quite a complicated question, should we take first the first two questions, then I'll come to the next members. Sarah, please.
Thank you, Chair. Donna's going to help me out with a couple of the details around some of the questions, because the mitigations are wide ranging, and I think she'll be able to give a bit more detail to committee.
Thanks, Sarah.
Okay, I should introduce you properly because it's
Apologies.
your first time today. Donna Glover, who's the Assistant Director, Assistant Service Director. I call her Donna, right? But and she's going to also help us present. Donna, please.
Thank you. Thanks. As these relate to operational areas, I've stepped in just to provide a response that I hope will be helpful. So just on staffing and safeguarding, you asked the question about whether those AMPs, those aren't AMPs, those are mainly qualified social workers. Probably in our safeguarding service, the multi-agency safeguarding hub, the MASH, it's one of those areas that carries a large amount of risk, and we need to make sure that our ratios of qualified staff versus alternatively qualified staff is higher than we might be able to accommodate in some other areas. And we know that bringing in professionally registered staff like social workers is more challenging, hence the risk around staffing levels is referenced there. There are some wider mitigations being put in place around workforce planning for our internal staffing, to make sure that we're identifying the right pipelines to be bringing people in, growing our own, etc., that's outside of this risk register. But I hope that helps.
Chairman, very quickly, I did ask a second question. Are we doing anything in particular to try and retain them?
So generally in adult social care, we've taken various measures to retain staff, and that work continues. So last year we introduced 6 protected days of professional development time for staff to make sure that those qualified staff have got the time and space to do the development they need to maintain their professional registrations, which is a requirement of that role. We're acting at the moment on the results of the staff survey. And Patrick led a staff feedback session recently to drill into more detail about what might help around some of those areas that staff have flagged. So yes, ongoing work across the whole of adult social care, including retention payments that have been in place for a short while in some areas of heightened pressure.
Could we get the answer to Councillor Black's question from either of you, please?
Yeah, I'm happy to start if that helps. So I can't answer for the public health ranking of the risks, and you'll come on to that next. But in terms of the risks that are referenced here in the Adults Health and Commissioning Risk Register around staffing. They're about our internal workforce predominantly. And I'm content that the way they're rated is correct. So we do have some pressures. We would like certainly to see a better pipeline of professionally registered staff, which links to my previous answer. But we don't have a huge issue in terms of safety, in terms of running our internal services. But I think you were linking over to the external workforce, and actually a large part of what the council does is delivered by an external workforce that's employed by external providers. Actually, at the moment, that market's quite buoyant. It's been really buoyed over the past year or so by international recruitment. Now, there may be some changes in that with some of the changes in rules around those recruits being able to bring their families to the UK when they come here to work. But at the moment, particularly in home care, for example, we've seen an oversupply in the market, which has really bolstered it. So it isn't, in terms of numbers of workforce, a risk that we've got flagged for that external provider market at the moment. But obviously, we keep a watchful eye on it.
I also just come back in terms of the rating comparison. Obviously risks are rated in terms of likelihood and impact, and although the type of risk might be similar, there could be different ratings. So the impact could be much higher for public health, for example, around particular providers if there's only one route. So for example, primary care, which we talked about earlier, the impact of something could be much higher. So when we're looking at the scoring for some of those, there could be slight nuances that are particularly pertinent to one directorate or another that would have a slight change in terms of that scoring methodology.
Okay, I've got a lot of members, so I'm going to move back to the members' questions, please. The first one is Councillor Costello.
Thank you. Yes, it's about risk 3 on page 157. Arrangements to support people with learning disabilities result in poor outcomes due to uncertainty of decoupling of funding arrangements via the Section 75 agreement. Now, earlier on today, we agreed to sanction a new Section 75 agreement, but in this area of the risk assessment, it says notice has been served on the Section 75 arrangement, legal advice in place to support ending the agreement. I'm confused. I don't understand it at all.
It's a big question. Okay, but I'm going to drive us on with the other questions so we don't lose too much time. But it is properly noted, don't worry. Councillor Slatter is next.
Okay, I was going to say that the risk number 7 should probably be read. And then hopefully after the decision we've just made, it goes back to Amber. But I really think seriously that item 7 is a big one. And even if we can arrange things better in some areas, it's in danger of going into the red in various places. So I would be interested to know how we're wishing you well, really, but I think we have to be realistic as to where the problems lie, and it is in this complex business of the ICS.
Thank you. Next one is Councillor Boulat, please.
Thank you, Chair. When seeing all of the risk in Amber, I also asked the overall question whether we're a bit too conservative with some of the risks, especially when we involve staffing and given how much time we spend on discussing the staffing pressures. But I have to say the previous answer to Councillor Black's question does make sense. And I think to be useful perhaps for members to look at what parts of the service have what type of staffing, this balance between external and internal staff, the percentage of international recruitment. I think all of those are factors that do decide to inform the risk that we have in staffing. And I think to me, just looking at the various levels of the service perhaps is not very clear to what extent each part of the service relies on, for example, international recruitment more heavily than others, which will bring a different level of risk compared to having staff, let's say, in-house for parts of some of the service delivery. But my question was around risk 3 as well, which is on learning disabilities. Just wanted to ask for some clarification there, because one of the triggers mentioned here, it says one of the risks is that we're not achieving the best outcomes for people with learning disabilities and autism, because the governance arrangements might not support what is called the right conversation and decision making. So I was just trying to understand, what does that mean in practice? Like, where is that, where is the risk in terms of the governance arrangements, and if there's anything we can do to mitigate that specifically? Because I have to say that's, an area that I think we should really prioritize as a council, especially around people with learning disabilities and autism. I think those are very important topics we need to prioritize. Thank you.
Thank you. I'm now looking at Councillor Van den Ven, please.
Thanks. Just to reiterate Councillor Slatter's attention to number 7, relationships and governance across the ICS don't support the best outcomes for a population. I do find it very helpful to have this here to really focus our minds. This is a really difficult area, and we are seeing examples where things would be really good if they worked better. So that is a job for us to think about. Thank you.
I've got 3 other members, but just to make sure that it's bite-sized and we have a proper debate, I'm going to break there and ask Sarah to go back on that round of questions, please.
Thank you, Chair. I'm going to take the 2 elements that related to risk 3 together, if that's okay. So in terms of the first question, which was around the Section 75 agreement and the earlier item in the agenda today, the agenda item earlier was a Section 75 agreement, which is a form of contract between ourselves and CPFT for the delivery of the occupational therapy service. The separate arrangement, which is around the learning disability partnership, is a separate Section 75. So there's different service specifications and requirements around each of those agreements. So the one with CPFT around OT is one aspect which that service runs and is delivering what we need. The Section 75 around the learning disability partnership is a slightly different and separate agreement with the ICB, I believe, rather than CPFT. So they are 2 different contracts, if you like, if you want to look at it. So they're separate things. So hopefully that saves any confusion. And I'm going to pass over to Donna in terms of the other query raised by Councillor Boulard.
Thank you. So this was around the risk of not having the right governance resulting in, less than the best outcomes for people with learning disabilities. So we put this risk in as the notice on the Section 75 for the Learning Disability Partnership was served, because we know there's a risk that if we're not having the right conversations with our partners to establish what future arrangements might look like and how we transition as neatly as we can to those, that there could be an impact on the people that we're supporting. We have put governance arrangements in place. Those are holding at the moment. That includes our own internal governance to do the work that we need to do within the council, and also the conversations that we need to be having with our ICB partners and also CPFT, who are part of that sort of triangle of arrangements in the LDP. We've kept it on there as a risk because we're still moving through that process. We haven't got to the point of some of the big decisions that we need to make about exactly what that service looks like in the future. So in a way, we're still testing whether that will hold and bring us to the right outcome. So I'd like to keep it on there until we're a bit further forward.
And just in terms of the risk 7, which is around the ICB relationships, Patrick's going to provide a response in terms of that.
Thanks, Sarah. So what I would say is I think it's right that we have that risk there, because there is a significant consideration, particularly around the impact if we don't make those relationships work. But I would say myself, Donna, Sarah, Will, and other senior officers and other officers within the directorate are working hard with our partners in the NHS. And I'll say that in its broadest sense. So the ICS is the Integrated Care System rather than the Integrated Care Board. And I think it's right to talk about the Integrated Care System who we're working with. So that includes colleagues in the ICB, but also colleagues within the acute trusts, both North West Anglia and Community Cambridge University hospitals, as well as the place-based accountable business units of the North and South place-based partnerships. I think and CPFT as well. So we're working with lots of NHS partners. I think we're building stronger relationships. We're having more open and honest discussions. And I think we are on a positive trajectory to doing much more work with our whole integrated care system. But I think it's right that we have a risk there. And I think the risk is rated appropriately at this time. But our mitigations within there, particularly around building stronger relationships, is the right approach that we're taking. And I think we are seeing some positive movements, particularly within the integrated care system as a whole.
And you modestly didn't include yourself in that list of officers who are pursuing those relationships, but I know personally that you are very much also leading on that. Thank you. I'm now going to ask Councillor Skeef to go next, please.
Thank you, Chair. This is in relation to risk number one. When I was a young man in training, I remember my principal telling me and giving me a piece of advice, which I've never forgotten, although I haven't always observed, which is choose your partners very carefully in life, generally, and in business. And this particular risk refers to the partners that we choose. This was a new risk in October. I don't remember, we must have had a discussion about it. I accept what is being said here, that the partnership's financial status, and etc., is being monitored on a regular basis. But I don't remember us talking about who are these partners. I mean, presumably public sector on the one hand, but also private sector partners that we work with. And I'm particularly interested in political stability. Are we commenting? Are we commenting on some of our public sector, or are we worried about them? And in particular, obviously, there are many, many different partnerships there. Are we more vulnerable to some than others? So that's sort of wide-reaching question, and it may well be that it's too sensitive for you to tell me who you're worried about. But clearly, you are worried about it because it's still a risk 8 with a level 4 impact. So that's what I would like to ask.
The officers will choose to answer that in the way that they do. Councillor Daunton next, please.
Thank you. Well, I think Patrick's more or less answered my question, which was about risk 7. I would just add on to that, though, if I might. Patrick's just explained very clearly that a lot of work is going on talking to partners in different parts of the directorate. There's also financial risk to that because of the human resource input that actually it's taking to make this partnership or this set of partnerships work. And I just wondered if you could comment on that.
And last one is Councillor Murphy, please.
Yes, thank you very much. I suppose I'm really picking up on something that Councillor Boulat said is, and I'm looking in particular at risk 6. It just really struck me looking at this risk that we have a risk that people needing care may suffer poor, potentially fatal outcomes, and because of abuse or neglect that the local authority was or should have been aware of. And the likelihood is low, but it's not 0. And the impact is 4. And it's just struck me that the impact is, is existential. And that may very well be the case for many of the risks that we face. But the impact on, as I say, on the adults with care and support needs, potentially fatal, and that it's hard to think of a higher risk than that. So I just wonder if some of these risks, either the impact could be a clearer concept to members, or
Are they a little bit conservative? I just asked the question.
Fair question. Although what I will say is that every interaction I have is that safeguarding is a very, very high priority throughout the service, as it should be. One question from me, which is the risk, which is about having proper management information overview, which sounds very boring, but actually is rather important to so that you and we get the performance overview we need, including the dashboard project and information needed for the CQC inspection, which of course could be imminent. And so if we don't get that right, we're really in trouble. So I can't see that in the report and not ask you how close we are to getting that right or wrong, and any latest information that you can share with us about how satisfied or not you are in relation to that risk. Sarah.
Thank you, Chair. I'm going to hand over to Patrick for a response in terms of risk 1 and further outline in terms of risk 7 and the ICS partnerships, which was the councillor's question.
Okay.
Yeah, thank you, Chair, and thanks, Sarah. So on risk 1, this was a piece of work that we did post the decoupling with Peterborough City Council. So we have a significant number of joint commissioning arrangements that we had when we were coupled with Peterborough, and as the process of the decoupling took place, it was felt necessary to review our risks around joint commissioning arrangements. And in doing that, we also identified that we'd got other arrangements, such as the Section 75s that were touched on earlier in occupational therapy and with the LDP. We also have one in relation to the Section 75 around mental health services with CPFT. So they were all part of that consideration. We haven't called out individual organisations that we are joint commissioning with because it's just a general risk that we wanted to highlight, particularly with the financial position that both ourselves and our partners were facing, that actually if financial positions change significantly, how would we respond as a council to any joint commissioning arrangements in terms of sharing of risk, in terms of default on contracts, etc. So that was why it wasn't highlighting any particular risk with any particular other organisation. It was more of a general risk around the joint commissioning arrangements that we have in place, and to consider going forward, how do we look at joint commissioning arrangements and partnership arrangements, and where the risk is managed and where the risk is identified, both from our perspective, but also from any partners.
Councillor Skeef and I are both not laughing, but smiling at the high levels of diplomacy that you exhibited in that answer, but don't think we don't know. Any more from Sarah or Donna, please?
I think Patrick was going to just pick up on risk 7.
So just on I'm not sure whether I'm going to answer this question or not, but just in terms of the relationships that we've got. So what we've done is we've reviewed, there are lots of meetings that take place with our NHS partners and our wider system partners. So we've reviewed our attendances at that, and we're making sure that we are sitting on that. So we now have representation on the North Place-Based Partnership and the South Place-Based Partnership. We have representation on the different quality and finance groups. You'll be aware, committee, that Chief Executive Stephen Moyes sits on the Integrated Care Board. Myself sit on the Health and Wellbeing Board of the Integrated Care Partnership. We're starting to have meetings regularly with NWAFT and Cambridge University Hospital. So there are many meetings where we're taking place, where we're all starting to share what our priorities are, what our strategies are, what the strategic ambitions of the council are, and how we're all working together in a more effective way to tackle those. Hopefully that answers your question. I don't know whether it does.
Yeah.
Any final points, Sarah?
Not in relation to that particular question. Donna's going to take the next one, which was in relation to risk 6 and adults with care and support needs who suffer potentially for poor outcomes.
Thank you. Yeah, thanks for picking this one up. But it is a tricky one to know how to pitch, and we're constantly reviewing it. it's there and rated as it is because of the breadth of the work that we do and the responsibilities that we have. So while we believe we have robust safeguarding processes in place, on a day-to-day basis, that requires our practitioners to be taking decisions based on information that they have at the time, to work closely with people, families, those around them who might be concerned, etc. And there continues to be a high risk around that, that you make the wrong judgment call, and that actually, we see a poor outcome for an individual. Thankfully, that happens relatively rarely, really relatively rarely. But it's a risk that it's not quite possible to entirely mitigate against, other than to make sure your practice is as sound as it can be. So it remains there because of the nature of what we see. Yeah.
Thank you very much, Donna. And in terms of the final question, which was around management information, and the ability for us to have oversight against that, that's part of my role. So that would be the area that I'll be taking forward. But in terms of the work that's happened to date, a lot of the Power BI dashboards, which provide a whole range of our different levels within our structures, that information to make day-to-day decisions, as well as giving us an overview from a directorate perspective. That phase 2 delivery of the dashboards is just coming to an end now. So we've got most of things in place. I think there's a number of things that we probably just need to make sure we've got absolutely everything that we need. So that's helpful. And we're going to be looking at how that relates to the risk and bringing some of that risk level down. In terms of how that links then with CQC, we're much clearer now, I think, on the CQC information requirements that they would like us to be able to show them. So we're doing a lot of work to make sure that we've got all of that information in place, and also looking forwards, how we make sure that we're having those performance conversations at the right level. So again, not just bringing to committee the indicators that are in the performance report that's later on in the agenda, but also ensuring that we've got that widest view against all of the statutory returns and also our operational and commissioning data as well. So trying to bring that together in a kind of overview of the directorate. So I'll be working on that going forwards as well. But I think that risk rating will come down. There's been a lot of activity, and the business intelligence or insights team now are fully engaged in the work that's needed around both CQC and the day-to-day operational management.
Thank you for that last answer, and thank you for all the answers. What we've proved in that debate is that you can question almost every one of the risks, and so that's what we've done. And Val's already looking forward to the next report with eagerness. So I've listened carefully, and for the minutes, I think the points made by Councillor Costello at the beginning, Councillor van der Van, Councillor Slatter, Councillor Black, I would say risk 3 LDP and risk 7 relations with the ICS and risk 8 the care market. And I know what Donna said, but that's quite against the backcloth of quite a difficult situation both locally and nationally. I'm going to suggest that in the minutes that we say those are the ones that we've raised most concern about, and ask officers not change the risk rating, but ask officers to be vigilant in future assessments of those risks. Have I missed one off my list that you'd like to add, Councillor Slatter?
Chair, I was actually wondering if we could add in with the mitigations in future reference to the Care Academy, because that last discussion of risk 6, for example, it's being alert to the problems which can lead to abuse and neglect, and some of that is allied with training, and we are taking on a big piece of work with the Care Academy, but I think it's where we can also reduce the risks that the council should have been aware of, and therefore reduces our risk of being held responsible for.
Okay, thank you for that clarification. Mitigations are there under each one, but I think you're highlighting the importance of them there with the particular example that you've
I'm asking, are we allowed to add mitigations or even just suggestions? In which case I've added it.
Thank you. We're asked to note the report. Nod or shake your head at me, please. I'm seeing nods all the way around. Thank you very much. It's your big moment, Val. Item 8, Public Health Risk Report, pages 177 to 190. Val Thomas, Deputy Director of Public Health.
Thank you very much, Chair. I think Sarah very well described how we manage risks within a local authority. So we are similar in public health, of course. I will sort of just give an overview of the themes, pick up on a couple of points where there was a crossover, and then open it to questions. I think there's some, throughout all the risks, there's some key themes. Some of them are very much external risks, in the sense that the cost pressures, inflation, increase in demand post-COVID, the uplifting of the public health grant not being sufficient to meet these pressures, and the workforce shortages. And these are the operational risks that are referred to in there. One thing about the workforce is that I think we're not comparing like with like. I think the public health workforce, there are two different types essentially where the pressures are. There are highly skilled specialist workforce that you'll find in drug and alcohol services or in sexual health services, and then there are the behavioural change cohort. And I think that's where there's a particular pressure. I think as the roles of different organisations, particularly NHS, change and focus more on a preventative approach, they are also keen to recruit those staff. So it's actually created real pressures in the market. The strategic risks are very much around the system-wide collaboration around public health outcomes. And I think we've come a long way in that, but there are some steps that really need to be taken if there's going to be really real change and improvements and a focus on prevention. Those pressures, those operational pressures, I think are described, they play out across commissioning, they play out across performance management and all those systems. And the mitigations are described very much focusing on how we make, we're working with our commission services about how we can make recruitment attractive, how we can make jobs attractive. We have an added issue there, which I didn't mention, is that a lot of short-termism of grant which funds these staff. People will not go for jobs when they know at the end of a year they might go. But we try to work creatively with our providers around those workplace pressures and similarly with efficiencies in services. Internally, in terms of our processes, we've done a lot of staff training and the development of things like internal procurement trackers. We have a website where providers can report any severe incidents. And this is developing all the time, and we've been doing that over the past year. I think in terms of the strategic issues, I think we've come a really long way. We have the sort of joint health and wellbeing board and integrated care partnership, and certainly have had some good examples of very collaborative work working on the 4 priorities. But there's something about pushing that a little bit further now if we are going to get some real investment in prevention. And although it might take a while, it's the prevention that will impact in the longer term on those inflationary pressures and on those demand pressures. I think we have very good representation at, like as Patrick described in adult social care, at all the key partnership arenas, both in the NHS but also outside of the NHS as well. But there's still that step in the system if we are really going to move towards prevention and getting better long-term health outcomes. So happy to take questions in any more of the detail, but attempted to give a summary of the key themes and a summary of what we are doing to address them. And just one point, I don't think we've had any CQC inspections in public health services.
Thank you for all of that. I did say I'd come back to Councillor Black if he wanted to come back. Do you want to come back at this point?
Well, actually, Chair, I think my main point was a worry about whether we were not alarmed enough in the commissioning than whether this was realistic. But I mean, we've got a risk of contract failure in our commission services here. Now, in commissioning social care, we've had a provider just walk away from all its responsibilities with domiciliary care and make all its staff redundant, putting them at risk of deportation, and had to rearrange everything for the looking after 120 or so people who depended on our services. And then a little bit further away, 3 of our care homes in the county, one of the big 5 care home providers walked away from our county after a series of disgraceful failures from the CQC of being marked required improvement and inadequate. And again, there are lots of staff who could work in care put in jeopardy, people's lives perhaps being shortened by being moved from one home to another because of the greed and obstreperousness of this provider. Yeah, I suppose I just asked, have we got anything that bad going on in public health, please?
In terms of CQ.
Could you take, we're going to take a few together, Val, if you make a note. That was a very clever question, was heard by all the adult social care officers, but feel free to give a brief answer to that, because I think it was more aimed at them.
Yes.
I'm going to take 1 or 2 other members first, if I may. I'm going to take Councillor Costello next, please.
Yeah, thank you. Again, it's risk E, which is red, and it's on page 185. So it says here, the second thing down, about workers going to be attracted to organisations that can pay higher salaries. As there is funding in the public health budget, which there's an underspend, why are we not offering higher salaries? It seems a simple solution.
Sometimes the simplest questions are the best ones. Councillor Van der Ven.
Thanks. I guess I'm looking at insufficient resources to maintain service levels, but also E, which Councillor Costello just highlighted, and its relationship to the whole council. I mean, the knock-on effect of worsening population health and the impact on social care is enormous. And given our health and all policies approach in this council, I would think that this set of risks would be of interest across the council. And apologies if I missed it, but there's also the pandemic response in D that we need to take note of, I think. Thank you.
Councillor Daunton, please.
Thank you. I've got 2 points of information, please. You've referred to the grant projects and short-term nature of grant income and grant employment. Are any links made between the people who are in post funded by grant funding and the possibility of their then being recruited into substantive posts and dealing with the recruitment and retention shortage? That's one question. And then very specifically in relation to risk of poor commissioning governance, it mentions under contingency plans training. I'm assuming that the training is mandatory for everyone working in commissioning. Could you just comment on that?
And the only thing I'm going to add is to strongly agree with your point about and still how far we've got to go to get prevention really working in the system, despite everyone saying that that's what they want. So I'm not disagreeing with anything, but I'm underlining the importance of what you said there. I've missed 2 councillors. I think therefore I'm going to ask Val to come back, because there were quite a lot of questions there, and then have another round. Val Thomas, please.
Thank you, Chair. Just a quick thing on CQC reports. I can't really comment, as we haven't had anything in any CQC reports on any of our services in public health. So I'm not in a place to respond to that question. And I'll leave it up to colleagues if they want to. There was the question about underspends and higher salaries. I think we noted 49k we underspent this year. It really would not, in a very simple answer, is that it would not really address the problem, that amount of funding. I think there's a much broader issue in that, in terms of the public health grant not increasing at the same rate of inflation and other costs. So we just can't keep up with it. And the underspend has been not because of lack of demand, it's because of primarily primary care not being in a position to deliver. So, you know, it's fundamental is that the public health grant really has not kept pace with other financial pressures. I'll come back to the pandemic responses. That's slightly different. I think you asked about the grant position, Councillor Daunton, in terms of recruitment and retention. Yes, there's a lot of communication across the system between different organisations about how staff can be redeployed and used elsewhere. It doesn't, with the very highly skilled staff, like specialist sexual health nurses or specialist drug and alcohol nurses, that's not quite as easy because they're just not there effectively. So it's working with providers in terms of how they build training into their services to secure that long-term solutions. And the second one was you said mandatory training. Yes, within the local authority, there's mandatory training around, certainly around procurement and around the new procurement regime, which public health services must abide by now. But we've also been able to send some of our staff on external training as well, focusing on very much commission and contracting and very much a transactional side of it. Going back to the pandemic, I think that the concern was more around, like there's always a concern, there's always the possibility that we can have outbreaks, hopefully not at the scale we've had before. I think we have staff in place which work very closely with the United Kingdom Health Security Agency, and that enables us to respond swiftly. There was a wider concern around the responses to emergencies, more the wider emergencies such as flooding and the impact on public health. And there have been a lot of training sessions that have been across the system, led by the Local Resilience Forum across Cambridge and Peterborough, to ensure that organisations and staff within those organisations are better prepared to meet any of those challenges as they come. Is there anything else that I missed?
Well, I've got two other members, so I'm going to take them next.
Yes.
Councillor Slatter is first.
Thank you. First, a suggestion, then a question. Risk E has already been talked about in terms of the shortage of staff. I just suggest that we should be trying to catch our youngsters young, and work experience, if it's done well and enthusiastically, could give them a good opinion of local government and make them come back, even when there are lots of other people dangling really nice contracts in front of them. That's one suggestion. Risk B is the one I had a question about. It's just a matter of information, really. We referred to diversity in Risk B. Go back up to it. I'm sure you can all read for yourselves. And I wasn't sure what is meant by increasingly diverse needs across the populations. I mean, we know that different people need different things in the way of public health provision and education. Could you explain that? Because I'm not sure how you assess it if we don't understand it. Thank you.
On your work experience point, we do have the chair and vice chair of the staffing committee in the room, so they're listening as well. Councillor Seath, please.
It's a funny thing you should mention that, Councillor Slatter.
John is going.
No, because I was going to pick up a similar point. I think that whereas with the adult health programme, I mean, you can use algorithms to work out what demand might be or pressures might be. With public health, you are taking a number of initiatives, which are 5 of the risks, I think, which you deal with. And then there are 2 that are totally outside the control, it seems, of their exogenous risks, which you don't know how they're going to hit. And obviously the one concerning pandemics and the like is one, but the other one is diverse needs. I also didn't understand it, but I think I've interpreted it slightly different from Councillor Slatter, that there are different types of prevalence of diseases, either communicable diseases or anything else. I don't know, prevention of accidents. I'm not sure that what you're, rather than diversity of peoples, but the diversity of the type of issue that you deal with. So again, I'm seeking some information on that, and how you. Well, I mean, with the pandemic, it's assessed as the highest possible risk, and there are indeed. We know measles is one that could hit us or our youngsters at any time, and I just don't know how you prepare for that. So that's my question.
Thank you. And last speaker is Councillor Boulat.
Thank you, Chair. I'm afraid it's on the staffing capacity risk as well. I actually do think we do try a lot at the local level to mitigate against this risk, but ultimately the reality is that to address this problem across the UK, there's like two main options. One is training people already here that we're trying to do with the Care Academy. We're quite lucky, I think, in our area to have a devolved adult education budget. Many areas don't have this as well in terms of skills provision. But the second is, of course, international recruitment. And the reality is we need both of those in the current economic context. As much as the government wants to pretend we need to reduce immigration more and more and put further restrictions on social care, visas, I just think currently we just have to be realistic that it doesn't really work in many parts of the service without that. And my question is, I actually wonder if this can actually become worse before it can ever become better, especially in the service parts that rely on some international workforce, because of the recent, I think it's due in a few days' time to be implemented, if I'm not wrong. It's March 2024. The restrictions on bringing the dependents to the UK is something I raised again in other settings as well in the council. I'm really concerned this will actually further affect our part of our services, because you're basically telling to people not only to come on short-term contracts with those short-term grants that we've been discussing, but also to leave their children and spouses at home as well, whilst doing jobs that are absolutely necessary in the economy. And to me, I think this is poses an additional risk for the part of the service that actually do rely on some international recruitment. I know previously we were told in committee that this is not likely to have a big impact, but I think, just seeing the direction is going with more and more restrictions on immigration in my view, desperate bid just to modify a bit the overall net migration figures, I think we're actually hurting the services that we need the most in this country. And I'm really concerned personally, I just want to put this on the record, I'm really concerned about the impact on social care in general and some of the jobs we have in the council. Thank you.
Thank you, Val.
Thank you, Chair. Yes, I would absolutely agree that work experience can be important in terms of building up a workforce over time. We do encourage that. We encourage our providers to use apprenticeships as well. We're also working with the Combined Authority in building in their skills and training into some of our programs. I think it's a really important route to go down. And we often get asked about the internal public health workforce as well. We have a training scheme around the public health registrars, but we also have sabbaticals, people coming to observe and support, and also provide support as well, a very valuable support in many cases. So yes, we are very open to every opportunity to build the workforce, including work experience. I think the question around risk B is needs a bit of an explanation and probably reflects the wording. I think, yes, there are diverse needs across the population, but I think it describes the situation as a shared service, as we are at the moment. Public health works to different systems that have different processes, they have different legal processes. In some cases, they take a different approach to procurement. And I think there's stress on the workforce and on the capacity of the workforce more than anything to serve for all these processes. And then that plays out certainly in terms of loss of efficiencies that can be gained because of very often the staff duplicate processes to meet the needs. to meet the needs that are necessary for commissioning and so forth. I think the question was about, it was an interesting question, how do you prepare for a health protection situation? Well, I think there's some very well-known public health areas where we prepare, most notably around immunisation and vaccination. It's information to the population in terms of protective messages that they can take. We have a very robust surveillance system where we and working again closely at regional and national level, where we look for potential triggers of any potential threats to the public health. And we have suitably trained staff to respond as quickly as we need to. And so, for example, we are working very closely to increase some of our childhood vaccination rates, particularly in the context of measles, which I think you're all very much aware of the current situation. But I can agree there's always the possibility that something might slip through, and that's why sort of public health surveillance is so critical in terms of protecting the health of the population. I think the comment on capacity is that we are where we are, and we just endeavour to work as much as we can with our providers, with our partners across the system, as how we can most effectively use our workforce. An example of that is there's a cohort of workers, what we will call behaviour change health trainers, that work with people around their behaviours. But we also find within the NHS integrated neighbourhood teams, they have a similar cohort. So we look at how we can use those more effectively, and rather than duplicate roles, we look at how we can complement and work more collaboratively together. And I think that has worked in many areas, certainly working at place-based.
Thank you very much. We're asked to note the report. Can you nod at me if you think that's a good idea? Anyone want to shake their head? No, that's unanimously agreed. Thank you very much to Val. Now, we are running late, so my suggestion to the committee is that we try and deal with the two performance reports. And those two reports very concisely. Ask the officers to do just a very short presentation. Of course, if people have got questions, they'll be fully given time. But but next time we'll make sure that performance reports are structured earlier. So I think we've benefited there by dealing with the risk reports in good detail. And I think we can do the same on the performance reports next time. So that's my suggestion of how we deal with it. Having said that, can we take the next item, which is the adults performance report, pages 191 to 210. So do you mind just giving us a minute or two maximum, and let's see how many members have got questions.
Thank you very much, Chair. So the report you have in terms of the Adults Health and Commissioning Directorate performance covers Q3, October to December 23, and provides an overview against the key performance indicators, which the committee reviews on a regular basis. The summary of the report for the delivery against the performance in Q3 is shown in 3.1 of the report. A quick summary in terms of the performance is that 8 of the 11 indicators that we review have improved from Q2 to Q3. The 3 other indicators have had small shifts in declining, but we will continue to monitor that into Q4 to see if that trend continues. Thank you.
And of course, you can't have every indicator improving every time, or we end up with Soviet Russia and we're 101%. So, you know, that is what you'd expect, and it's important to have reasonable expectations here, as well as obviously wanting continuous improvement. Any questions from members, please? Just one from me then. I think it's a bit unsatisfactory that we have such low response on carers. I fully accept the explanation, which is the carers conversations are working. I've got no problem about that at all, but I think we have to capture that in statistics. We can't just say that. So is that something that you can look at?
Absolutely. We are looking at in terms of the all age carer strategy, etc. as well. So it's one of the things that I want to look at in terms of the carers metrics, also in line with our feedback from our carers as well. So absolutely looking at how we can have the data that reflects some of the good work that's happening in the directorate.
Thank you. The recommendation is to note the report. Nod at me if you are happy with that. Fine, lots of nods. Any shakes of heads? No, that's agreed unanimously. I didn't see a shake. I really didn't. Shake, rattle and roll. That's what we do in this committee. Item 10, Public Health Performance Report. Similar approach, just 2 minutes, please, Val.
Yes, I think the format follows the adult social care format, so I won't repeat that. I think that the improvements across the indicators very much reflect the last quarter, and it's continued with the exception of course smoking cessation, which I addressed earlier in the meeting. And I think that as our main concern reflects I think it reflects very much at primary care. It's a longer type of expectation from them in this service, and they just don't have the capacity. And it reflects the fact that the focus is on where we have the highest rates of smoking, which are in certain population groups. And I think that's where we are reshaping the service in line with the national drive as well, because we are getting, as I said earlier, confirmed last week, nearly 900k for next year to address those population groups where rates are higher. So I think we'll see a shift from primary care, because I think the people we want to access do not access primary care services. And just one other thing I think to note on a positive note is that the performance of our weight management services, that we have a huge degree of demand for it, but we also exceed in terms of the quality of the service, where we're expected to get 30% of people going through services achieving weight loss. Our achievement rate is in the 40s, which is well above national benchmarks. So it's something the demand is way above the funding, but we do get very good outcomes.
And much as we properly focus on challenges in this committee, it's good sometimes to celebrate successes as well. So thank you for that. Questions on the Public Health Corporate Performance Report? Councillor Daunton.
Yes, thank you. So the question is on the NHS health checks. You've given the figures. Could you give us some sort of local colour on those, how even or uneven they are across the county?
Again, I'm going to take all the questions together, please, Val. The next one is Councillor Van de Ven.
Thanks. I wanted just to note the health visiting mandated check rising. So it's red, but rising, and what good news that is. And if you could just expand a little bit on that, because I know there's been a big effort. Thanks.
Thank you. And finally, Councillor Costello, please.
Yes, I'm on the health visiting one as well. I just wondered if the targets weren't being met because, again, of the problem of recruiting staff, because I know health visitors, are very professional and have lots of qualifications. And what are you going to do to address that?
Thank you very much. Val.
Thank you, Chair. In relation to health checks, yes, it is uneven. We set targets for practices. This is a practice-based service based on their cardiovascular disease prevalence. And we know that certain population groups experience higher rates of cardiovascular disease. How from going forward from this year, the committee approved funding for a prevention program in primary care. And part of that program is being, and it's being jointly funded now with the ICB or additional funding, whereby a system will be able to, parachutes into practice data records and will identify people who are particular high risk in practice records, and will send texts and letters and really target them with their need to take up their health checks, because we're very much aware that we need to hit the people who really do need to have the health checks, and where an intervention can be very timely and prevent an unfortunate health outcome. The health visiting, I think those figures reflect an awful lot of hard work on behalf of my colleagues that work on the Healthy Child programme, and work very closely with the providers in terms of recruitment of new staff, because I think you're right, there's been an issue on recruitment of a skilled workforce, and also looking at different types of models of service delivery whereby certain functions can be undertaken by staff with a different skill set. And I think that's probably the prime reason. And it was, I think, during COVID, the whole kind of checks evaporated a little bit for obvious reasons. So it's sort of building that system back up again, getting in the appropriate staff. And I think it's that factor that really shows different models of service delivery, and the recruitment has started to have traction. And I think, does that cover both the questions? Because I think they're very similar questions on the Healthy Child Programme.
Asking members, have I covered it, is such an invitation for them to come back, and I'm trying to get us to lunch. I think I'm not seeing any other hands. So are we happy to note the report, nod or shake? I think I'm looking all around the room. That's unanimously noted. Thank you to you, Val. So we've made good time there, and we move to item 11. First of all, the agenda plan. Tamar, anything to add to the written plan on Appendix 1, please?
No, nothing to add.
Okay, and I'll just note that we've already agreed earlier in the meeting that we want to add staff action to address staff vacancies, and then a second item, scrutinising the debt management improvement plan. And Councillor Van der Ven.
Sorry, it says committee appointments, and I just wondered.
We're not at that yet.
Oh.
We're doing the agenda plan first. There's
Sorry.
3 items here,
Sorry.
The next one is the training plan. Sorry, first of all, on the agenda plan, I'm seeing Councillor Daunton. And I'll take Councillor Wilson, then I'll answer.
Can I suggest that as part of the workforce plan, you include reference to the staff survey and what is being done about that? But I don't think that's something that has come specifically to this committee, although we probably have seen things on emails and.
Yeah, I think
whatever
that's a good
else.
idea myself. So as chair, I'm going to unilaterally say yes, please. Not to look at the whole staff survey, but the implications for recruitment that come from it, which are, clearly is consistent. Have I missed someone?
Just an answer to Claire's question.
Yeah, Councillor Daunton's question. I'm sorry, I was so focusing on the last one, I've forgotten. Oh yeah, the Vice Chair and I have agreed to meet today to discuss whether to have a development session on that day or not. I'm minded, because it's close to local elections, the normal instruction in the administration and with our opposition friends is that we don't have meetings so close to local elections. But there are interesting proposals around possible development. So are you happy to leave it to Councillor Van der Ven and me to agree that or not? And we'll let you know as quickly as possible. Is that okay? Thank you. And if anyone's got really strong feelings, they can lobby us. We next move to the training plan. Anyone got anything to say on the training plan? No, Councillor Slatter has.
Yes, as you know, I would quite like at some point members to have a good briefing about the the Caring Care Academy. Yes, that one is indeed, must have gone in and stuck. We've had a launch, but as we know, generally speaking, when there's a launch, the ship then goes around the corner into another dock and they do the real business. So I'd quite like it in a suitable time that to go on the member training plan or briefing, I should say, because we're not actually training to be carers ourselves. Thank you.
Yeah. Okay, I think that's a very apt suggestion. And Donna is very happy that we keep referring to the Care Academy, having worked on it for 2 years plus. Councillor Daunton.
Maybe we've done it to death, but have we had sufficient on partnership working?
Interesting one. I'll look at to my colleague Councillor Van der Ven and to Patrick as well, but I suspect that might be more part of a development session than a training session. I'm just looking at both of them. We'll think it's definitely one of them.
Okay.
I got 1.5 heads there, but I got a half shake.
I'll leave it with you.
I think the answer is yes, but how we do it, I think we'll just deliberate on. If there can be notice, we don't forget it, Tamar. So that's the training plan agreed. Finally, the point that Councillor Van der Ven has been eagerly waiting for, which is committee appointments.
Thanks. I only wondered if this relates also to our scrutiny appointments to liaison groups, and if so, I don't know, and if so, can we have some scope to add to that after we meet informally next week?
And the position is, I think we've said this a few times to the committee, and I'm not blaming anyone or criticising anyone, but particularly looking at my Conservative friends, we want these to be cross-party and we want there to be a good geographic spread. And if I know people are very, very busy, but I would particularly invite any member of the committee, as I understand it, anyone voluntarily can join. There's an open membership. So we don't have to wait till the next meeting. People could be invited as a guest basis by the chair or whatever, and then it could be subsequently noted. So please, particularly as this afternoon we'll hear the work starting on the quality accounts, particularly as we're going to start a new round of liaison meetings, can I invite all members of the committee from all parties just to think again whether you might want to add your name to one of the liaison groups, and Rashenda Greenhill is happy to provide you with the full list, but whether it's the hospital or acute facility in your area or that your constituents use, or whether it's a specialist area that reflects your interests. I really do ask people to look at that, and if we can add even one or two extra people on overall, I think that would improve the quality of what we do. Not to say that we're not doing a good job already, but that definitely a more diverse, to quote Councillor Slatter and Councillor Steve, a more diverse participation would be very, very welcome. I did see a hand, I think it was Councillor Slatter.
Yes, because when I bring this up informally with you, Chair, I wasn't at all sure what position district councillors are in, because we've had some really good contributions from district councillors coming to scrutiny in the afternoons. And I'm sure that colleagues opposite will know some of their colleagues who would make a very good contribution to a liaison group. And I didn't know whether we are allowed to say or invite such councillors to it.
So thank you for raising it, and it's a good point. Just to be very clear, our district co-optees are very much invited, and in fact some take part already in the liaison groups. So again, if there are time pressures in any group, I'm not saying any one group, but in the Conservative group in particular, and you would want to encourage one or two of your district colleagues to join our groups, we would encourage that. And for Councillor Slatter, I'll remember to say that again this afternoon when the co-opting members are in the room. It's a good point. Anything else on committee appointments? Have I missed anything came up now? In which case, even though I'm out of practice, 3 minutes early, you've got your lunch hour. Just help me by being back on time by 2 o'clock at the latest. Meeting adjourned. Okay, I'm about to restart the meeting. Good afternoon, everyone. I would like to welcome you back to the second part of today's Adults and Health Committee, and we're dedicating the afternoon, as we often do, to health scrutiny. I'd like to particularly welcome our non-voting co-opted committee members representing our City and District Council partners, Councillor Corinne Garvey, Keith Morgan, Steve McAdam, Dr. Hack Nawaz and Rachel Wade. Councillor Wade is attending on Zoom, so I'm looking and seeing if she's there already. No, she's not, but we hope she will be soon. If you didn't watch this morning's session, we're just going to get a repeat of apologies, Rosenda.
Thank you, Chair. So apologies have been received from councillors Bowden and Hay.
Thank you very much. Any other apologies that anyone want to pass on? Councillor Murphy has had to leave. Anyone else? Councillors Corney, Reynolds and Howell have had to leave. Thank you for reading that into the record, but there's still a good turnout here, and thank you very much everyone for participating. As I have to, just a housekeeping reminder that there are no fire alarm tests scheduled for today. If the alarm sounds, I'll immediately adjourn the meeting. We'll leave the room through one of these doors on my left-hand side, and we will go out through the fire escape, whose door is opposite, down the external stairs and into the meeting point at the car park. Raise your hand if you want to speak, and Councillor Van de Ven and I will be trying to spot you and make sure everyone gets to speak when they wish to. If anyone on Zoom is there, put your electronic hand up and we'll notice that as well. And I think that is everything that I need to say in introduction. We've got a number of items this afternoon, but the first one, and I would argue the main one, is the thorny issue of dental health services. It's a difficult one, and we've had discussions with our friends from the ICB about the right timing to do this, because they only took over responsibility relatively recently, and we wanted to make it not so soon that they didn't have a chance to really assess the situation, but not too late that we didn't have a good chance to influence it. And I think I hope we've timed it right in terms of having this item on our agenda today. It's item 12 on your committee papers, and it's on pages 239 to 244, the report that they've kindly provided to us. We're joined and welcome to Nikki Briggs, who we know well, Chief Finance Officer for the ICB, and to her colleagues, Dawn Jones, Associate Director for Primary Care Contracts and Enabling, and Jess Bendon, Primary Care Contracts Business Partner. I understand that dental services also might be in attendance, but I haven't got a name. I'm also very pleased to welcome Caroline Tyrrell-Jones, who is Communities Programme Manager from Healthwatch. She's going to wave. And Caroline is welcome to contribute to the debate. And the most recent Healthwatch report on dental services has been redistributed to all members in advance of today's meeting. Committee members have read the report kindly provided by Nikki Briggs in preparation for the meeting. And so I will ask Nikki to give a brief introduction to that report, and then we look forward to debating it. Nikki Briggs, please.
Thanks, Chair, and apologies, I've got a really bad cold, so if I have to pause to either blow my nose or cough, I do apologise, and do let me know if you can't hear me and I'll try and speak up. As set out in the report, I think one of the key things to note is that the ICB was only delegated responsibility for dental from the 1st of April 2023. Prior to this date, responsibility for both commissioning, governance and engagement with everything to do with dental and dental practices fell to NHS England. The governance and framework for NHS dental services is provided through a national contract still, so despite us locally being delegated the funding and commission responsibilities, it's still a national contract for dental services. That's been in place since 2006, and the big move in 2006 was it moved away from the kind of payment for treatment into banded payments, which, to be honest, is probably where some of the decline of NHS dentists started and has continued since then. The ICB inherited a number of NHS dental contracts that have underperformed since 2018, largely due to the pricing structure of that contract. And just to give you an idea, in terms of the banding, there's largely three bands. The first one is for everything from a simple checkup all the way through to kind of x-rays, hygiene appointments, and that payment is £26. Private ranges from £10 to £90 for that work. The second band is £70 for anything from one fill-in to tooth extractions and root canals, which again privately is anywhere between £90 and £320 for those same things. And then the band 3 is for crowns, dentures and bridges, which is over about £300. And again, privately, those range from £400 to £1,000. So you can see where the problem is arising in terms of what the NHS pays dentists for that work versus what they can get privately. We recognise that dental access and activity is not at all where we want it to be for Cambridgeshire and Peterborough. And so what we have done is been able to put in an additional £6.1 million for a dental improvement plan, which will hope to increase access to dental services and support our communities. We're fully engaged with local providers. We've done 3 engagement events with our local dentistry providers, and we're engaged as well with obviously Healthwatch and patient groups in trying to drive that improvement and that dental improvement plan. I think the key thing for us is that we've got the ability to use our population health information and identify the areas where that resource should be focused. So we know where the access to dentistry is the hardest, and our improvement plan plans to focus in those areas. It's summarised in the paper, so I won't go into that, but also literally just as we were writing the paper, NHS England published the joint NHS and Department of Health reform for NHS dentistry, where there was some key initiatives such as those new patient payments, one-off payment to attract dentists, and changing and increasing those band rates. Glad to say that all of those things were already on our improvement plan, so we're ahead of where they were expecting to start nationally from the 1st of April. We do recognise that dentistry is a big challenge, and that has shifted responsibility onto the ICS. So we've made it a clear priority, and hopefully you'll see that in the focus and funding that we've put into our dental improvement plan and the engagement work that we're doing with colleagues and patient groups, we should start to see improvements in access and activity. Open for any questions, Chair.
Okay. If your colleagues aren't joining in presenting this point, Caroline, I'm hoping can come to the table. Maybe one person could just vacate it so we can have sufficient, and all the microphone can be moved across. So that's okay to do that. So Caroline Tyrrell-Jones from Healthwatch, please.
Thank you, Chair. Thank you for giving me the opportunity to come along and speak today. I was just going to say a little bit about what Healthwatch is hearing, both from a local and a national perspective. Obviously, we're here in the health and care system to listen to people locally, to hear their experiences and to share that with people who are in a position to make decisions. So dental care is something that we hear about multiple times a day at our Healthwatch alone. It's been in the top 2 issues that we've heard about every single month without fail since well before the pandemic. You can probably imagine that much of the sentiment that's expressed is negative, although we do get some mixed feedback as well. But we get an awful lot of people who are just exasperated with being able to access any form of dental care, including people who are in excruciating pain. So obviously we really welcome hearing what's being proposed under the dental improvement plan, and we look forward with interest to seeing how that's going and to hearing people's feedback as to how that really unfolds for them, really what it means for them in reality. But it would be good to think that we might be able to do something to address what's very much a 2-tier system at the moment, and a huge amount of inequality in terms of people's ability to be able to access dental care, either on a sort on a regular basis to prevent issues, but also when they're in urgent need. So, so obviously we listen to people very much on a local basis, and we hear their feedback, and we pass that to Healthwatch England, and obviously they're able to escalate those sentiments on a national basis, and we find that what they're hearing up and down the country is echoed really in what we're hearing locally, although we do know that we're particularly badly affected in this part of the country. With people, some people who are from sort of slightly more affluent backgrounds, I suppose, who are still equally affected, you know, in terms of not being able to afford to be able to access care. Thank you.
Thank you very much. Now, to Nikki and your colleagues, rather than just do random questions and throw them at you, we're theming them, and we hope that that's going to lead to an even more productive debate between us this afternoon. And the themes are as follows: firstly, budget allocation and contracts; secondly, training; thirdly, prevention; and fourthly, local provision. So to members, when I announced the theme, I've got some members already that I know are interested in that area, but then others can come in. But if you hold back your questions on other areas till we get to that, we've got an hour and a quarter, so we've got plenty of time to do justice to this. And I will make sure at the end that there's a catch-all time. So if there's something you've not asked that you wish to, that there will be an opportunity to do that. So you won't miss out, I promise you. So firstly, budget allocations and contracts, and Councillor Dr. Nawaz from the prior discussion is interested in asking about that.
Yes. Thank you very much, Chair. First of all, thank you, welcome, and thank you for coming, taking the time and trouble to come to speak to us. Secondly, having gone through all the paperwork, Chair, the ambition is great and very welcome. The need, I dare say, could be even greater to catch up with almost a decade of burgeoning need. If you do it, it would be a huge accomplishment and a huge relief to the population. My question is, now I have seen two figures. One is 6.1 million, which you have mentioned, and another one is 200 million, which probably emanates from the central government. What is your total budget for the ICB area in Cambridgeshire? And how will you allocate these resources between the different districts, bearing in mind that there are very substantial inequalities in dental health as well as general health? So will you be using any particular criteria to address the disparities in dental health between, say, Fenland, which is probably at the bottom of the pile, and I wouldn't want to hazard a guess who is at the top of the pile, but that's, I guess, in a way irrelevant. So would you please enlighten us on these plans? Thank you.
And just so we'll take 3, 4 together in a group. But if I've got lots more than that, I'll break it up so it's not too many. But if you can make notes of the questions, and we'll deal with them in rounds. The next one I've got is Councillor Boulat.
Thank you, Chair. So I would like to, on the budget theme, focus on paragraph 2.17, speaking about the minimum value of activity, which is, in a way, it's some good news from central government that's increasing from 23 to 28 pounds, but it's still less, it's far less than charges to private patients, of course. So the question is, how much of a difference would this make locally? And also related question to this paragraph as well, it does also mention that this minimum value of activity will only impact a small number of contracts locally. So I guess what members would be interested in as well to know is to what extent this will change in any way the local picture.
Thank you. Councillor Black, please.
Thank you, Chair. I just want to make a really brief point about what I think is the elephant in the room here. The DHSC says that the budget for NHS dentistry is something like a little bit under 3 billion for 2023, 23, and that is almost exactly the same as it was in 2010. And when you put it into real terms about the decrease in the money that's going into dentistry in this country, the British Dental Association estimates that it's fallen by about a third in real terms, and that they've cut $1 billion in real terms, and that we're just coming up to the biggest annual cut in decades. And I mean, in this context, I mean, are the efforts that we can make with what we've got in the ICB anything more than just a drop in the ocean?
I think Councillor Seif indicated, unless I got it wrong, it's for later. Is that similar for Councillor Costello? Is it now or later? Later. So Councillor Daunton, please.
Thank you. I have two questions. One is there any scope for learning from other countries, how they're doing it better, worse, and just how they're doing it? That's my first question. And my second question is to do with capital expenditure. So when you trying to encourage new practices to set up, is there support for the purchase of capital expenditure of equipment? Thank you.
My question on the budget, and please tell me I'm wrong, by the way, but the section of your report which is about the National Recovery Plan, when I compare what you write down and what I listen to on the radio when dental organisations come on, they say that the government's national plan is not really enough to make a difference. And obviously you don't answer for the government, and I don't expect you to. But you're obviously making judgments about how much of a difference it will make and how much you need to add to that. And so I think it is fair to ask you the ICB's view on that. And in your section on the local programme, you don't, unless I've misread it, you don't quantify the additional resources you're putting in. So to echo Councillor Dr. Nawaz's question, how much extra money for Cambridgeshire does the national government plan give us? And then how much additional money does your local implementation plan give us? Because that, unless I misunderstood it, I couldn't understand that from the report. And is it really enough to make a difference? What is the ICB's view in relation to that? I'll pause there and let you come back with some answers. I don't mind if more than one person wants to answer, that's fine.
Thanks. I think that's 6 questions, but if not, then remind me and I'll come back and I will bring in colleagues along the way, but I'll give it a good start. In terms of the total dentistry budget, the NHS still hasn't had any allocations or budgets for 24-25 yet. We are still awaiting planning guidance. So I can tell you what we've got this year, but anything further than that, it's not that I can't tell you, it's that I don't actually know myself. So I will leave you to think about how that.
This year then? Can you say the figure for
But I can do it this year. In terms of this year, we've got approximately £48 million, is just under that, of dentistry budget. And on top of that, the ICB has put in the £6.1 million. So as you can see, that's about a 15% commitment to the improvement plan. So it should make improvements and inroads into what we're really wanting to do. In terms of how that's moved, it's not separated out at districts. It's paid for based on the contract. So that's based on the number of dentists that hold an NHS dental contract. So it will depend on where those sit and what the geography is of that in that area. In terms of the second question, which is the minimum value of activity increases from 23 to £28. We said that as minimum value because some of our contracts are already at 25, nearly £26. We will monitor and see how if that improves. But as I said, in that lower band worth of minimum activity, privately they can get paid up to £90 for some of that activity. So we're in a bit of a watch and wait space in terms of whether that will have an impact as they're expecting. I think one thing that I will say on that in terms of what we're trying to do, and it taps on into some of the work that we're doing in the improvement plan, and also brings in the learning from other countries piece, which is we've engaged with a multinational organisation that are experts in costing, pricing and health economics, who are working with us to take Cambridgeshire data and get insights into dentistry that we just don't have. So they've been doing a lot of work to look at where our dentists sit, where the national contracts sit, what the time to travel for patients is for each of those areas. So, you know, where is that deprivation being caused? And it's not always where you expect it to be. So some of our South Cambridgeshire area, most affluent area, actually has some of the biggest problems in terms of people that have been able to access dentistry or not. And we've asked them and challenged them a question which says, given that we know that dental budgets underspend each year because dentists are handing back NHS activity or NHS contracts, if we were to maximise the amount of funding that we've got, what would a tariff look like that would attract dentists back into the NHS? So how does that work? What would that look like? And they're doing that modelling piece, and it's bringing in information locally, but also across the kind of multinational format in that space. In terms of, I don't know if it was a statement or a comment that I need to go back on, but the real terms funding increase, yeah, it's one of those, I guess, those sleight of hand movements that seem to happen every year of there's a big announcement about additional funding and it doesn't quite materialise. So when you look at that UDA rate, so that minimum activity payment, it has not increased that much since 2006. So it is not in line with inflation. As we said, we've quoted the private rates, it's not in line with that. And that's why we really want to do something different in that space. And I will say that our dentists are really engaged with doing things differently. They really want to get involved in the prevention regime. I know that's later on the agenda and we can talk a bit more on that one. I'll skip over the 200 million and come back to that at the end because I will bring Jess in on that bit. But in terms of capital expenditure, it's a bit like GP practices. They're private businesses. So the NHS can't give NHS capital money to private businesses. What we can do is if we set up community spaces or we work with them in some of our locality areas, we can access NHS capital funding to do that. So it's a bit of a mixed bag in terms of that capital, but the idea is that the NHS contract should pay them enough to be able to get that capital. But in reality, I think what we're going to have to start looking at in that innovative space is how do we look about using our community spaces better, and how do we make that more attractive, and therefore how can we access NHS capital through that. In terms of the NHS plan, and again, just sorting between the numbers that have been published nationally, the 200 million that's been assigned, we at the minute have received 780,000 of that 200 million. That's what's the equivalent that's going to come to Cambridge and Peterborough. Some of the 200 million is not new money. So just so that you're aware, and just to pick through the comms on this, I'd say the UDA increase from 23 to £28 is to be funded from ICB's current budgets. So they are to reduce activity to pay for that increase. That was what came down to the national guidance. So how that then links with a dental access improvement plan. Hence why, again, going back to focusing, we wanted to put that additional £6 million of ICB funding in. Do we know? I think the question was, do we know if that's enough? We don't know. That's why we're engaging with experts to try and work through what will have the biggest impact. And we've had some brilliant engagement events with NHS dentist providers who have said to us, this will work, this won't work. as I said, they really want to be able to provide some of the prevention work, and it's how do we fund that? Because they're not funded for that. So that's some of the bits that they think will make a real difference. Because actually, if we get the prevention right and we stop the flow through in terms of those emergency appointments, it'll be much better. Jess, did you want to add anything else on the 200 million?
Oh, thank you very much, Nikki. Yes, so with the dental van that was mentioned within the report, we have been highlighted as an area that will receive this extra resource, and that funding will come out of our dental allocation and has been included in our dental allocation for next year. So we will set aside a budget for that. And also for the new patient premium that was mentioned, we have been given a small amount of funding to support to the end of March, and we do need to monitor we nationally monitored to ensure that the credits will be given to those providers that do see new patients and get that additional incentive payment, as long as it doesn't go over their contracted value. If it goes into the 110%, which was nationally approved as another payment in 2022 as part of their reforms, then we can obviously support that through the additional funding. And going into next year, where this funding will be available, again, this will be monitored to ensure that none of the providers go over their contracted value in order to deliver that. Thanks.
Okay, also under this heading, I have from the preparations, Councillor Horgan, Councillor Van der Ven and Councillor Wilson, who might want to ask questions. Councillor Van der Ven has indicated. If either of the other two want to indicate, please wave at me. Councillor Van der Ven.
Thank you very much for coming, and it's great to hear about the engagement you've had with NHS dentists, and I understand that is new, that didn't happen before, so it's good to hear how much you're learning from that. Just a couple of simple questions, and apologies if I've missed it in the explanation so far, but how has the funding for Cambridgeshire and Peterborough been from government been worked out? And I'll just ask my other ones alongside. Would the ICB consider directly employing dentists who would only treat NHS patients? And a different question, could you explain to us where the funding for oral health promotion sits? I think we had a discussion earlier and weren't clear. We thought that some of that had gone to NHS England, but has that been transferred back to the ICB? I guess that will be important for our later discussion around prevention, but it's still a budget question, so I'm asking it now. Thanks.
No more hands, so straight back to Nikki, please.
Great, I'm going to hand this one over to Jess for all three of those ones.
Actually, do you mind? I didn't see Councillor Slatter, and I want to complete this section of the debate. So, with apologies, can I just fit Councillor Slatter in and then come back to you?
Yeah, I was just waiting to see if it was the same question as Councillor Van der Ven. My question, Chair, is prompted by the reference to the mobile vans. I haven't looked into these yet, but other councillors say that it sounds like a great idea. Are these being ring fenced as part of the money coming from central government? Because it looks as if under that bit, if I'm reading it right in these two sections, this is the new dental recovery plan, and it talks about one coming to Peterborough and Cambridgeshire. Is that because they've said that will happen? Because my associated question is, at what point do we say how much we need for any one of those sections? And some of that might have already been top sliced. I'd like to know both the vans and maybe other things that central government is telling us how to spend it. Thank you.
Please.
Great. So I'll take the first and the last one and then let the Jess pick up in between. So in terms of funding from the government, it's worked out on a per head of population basis. I'm not sure that in terms of dentistry, it's been reviewed since 2006. It will have just been inflation applied and efficiencies and everything else added on top. So I'm not sure there's been any review of dentistry funding since those. In terms of the vans, there are a number of vans, I think it's about 8 or 9, we in Cambridge and Peterborough have been identified because of the rurality of our population and some of the deprived areas to be one of the lucky folk that is going to get one of the dental vans. To pay for that, it has come out of our current dentistry budget. So it's not, we haven't had an increase in the budget to pay for the vans. We've got the vans and we've got to find the money in order to pay for the vans. They are unlikely to be active until towards the third quarter of next financial year. So just to kind of manage expectations in terms of when they will come online. Jess, did you want to pick up about the ICB employing and the oral health?
Yeah, of course. Thanks, Nikki. So yeah, the question around employing dentists directly, thank you for that. So in order for us to actually deliver this contract or be delivered by providers, all dentists must be on the national performance list or on some kind of conditions, which is a national process. And we as an ICB commission with dental providers directly, so they do the employing. So we wouldn't employ directly as commissioners, we employ through a service and then the service employs those associates. I hope that helps with that query. And with regards to oral health promotion, so since 2012 with the Health and Social Care Act, when NHS England was created, and the public health team moved into the local authority, it became the statutory requirement of the local authority to, for oral health and all dental public health. So that includes epidemiology. So I've been working really closely with the public health team and have been since I was in NHS England, because we have a contract with Cambridgeshire Community Services who deliver, it's either called a special care dentistry contract as we call it, or it could be called community dental services contract. So if it's mentioned in either way, it's the same contract. And as part of that contract, we have agreed with the public health team to retain part of the funding that we had as part of that contract to deliver oral health promotion. The service delivers that as well as epidemiology. And we're working, as I say, really closely with the public health team about which groups to support and looking at obviously the health needs data in order to do so. So that may change over this year about who will be prioritised for those pieces of work. Within our prevention, sorry, I'm slightly moving on, but with our prevention element that we wish to look at as part of the 6.1 million, again, it will be to complement the work that the local authority wish to deliver as part of their agenda alongside the work that the community services already deliver, so that we're not duplicating, but we're enhancing that offer of delivery and by providing additional funding to do so. So that is our hope. I hope that's answered the question.
Can you just put figures on, you're talking to the public health team, but does that mean that the amount of funding will go down, is the same, will go up? I didn't really, talking doesn't quite cut it for me.
So the funding, so sorry if I didn't explain that properly. So the funding that we have within the contract will remain the same with yearly uplifts. So unless the local authority wish us to undertake more, the contract and the value of the service will remain the same. And that contract is currently in place until 2026 with the opportunity to extend for another 3 years. And obviously that will be due through discussions with the public health team about whether or not to extend or not.
Thanks. Val.
Thank you, Chair. I'm Val Thomas, Deputy Director of Public Health, and it's a quick query about that, Jess, is that we've never been very clear about the amount that's come down. So therefore we don't know exactly what could be done with that amount. It would be really helpful to have that understanding when we're working with you.
Of course, no problem. I have offered to share that with your colleagues, so I will absolutely do so.
And it would be good then to work through how we could best spend it, certainly in that sphere, the epi side of it, but also the preventative side of it. Thank you.
Yes, of course, no problem.
That concludes the budget section, but thank you for addressing those questions. We're now going to move on to training and education. No, training is next. And the context is obvious that in terms of workforce planning, it's a big issue across health, but it is in dentistry. When we've done scrutiny before with the national body, getting a dental school in the region has been an issue. So we're interested about what you can tell us about that. And please, any members, you're welcome to ask questions again on training and education. Dr. Nawaz again was the first, but I then see Councillor Slapser, Councillor Seif and Councillor Daunton. Councillor Dr. Nawaz first, please.
Thank you, Chair. Actually, I did have one or two supplementaries for the previous section, but
you're welcome to do both.
Oh,
perhaps start with the supplementaries and then we'll take an immediate answer, just to be clear.
Right. Thank you very much. It is quite evident that you are working within certain fiscal constraints. That said, forgive me. That said, you also have in the paperwork plans for in terms of preventative as well as curative aspects, the preschool, primary school and secondary school, I assume. How do you envisage implementing those plans if, as you say, you have severe financial constraints? And I think that would form a very useful and indeed an indispensable part of preventative and curative plans of treatment. But may I also here say that your dental and oral hygiene is intimately connected with your general physical health. And it is, I think King's Fund has worked out, or the Working Party House of Commons has worked out that for every sort of pound you invest, you probably end up saving several pounds. So are those proposals still to be implemented? What is the timeline? And may I also suggest, you have quite rightly said that you have been engaging with the dentists as to how to implement these plans. It may well be in everybody's interests if you were to engage equally with the constituent district councils and their representatives. They're the people who are on the ground. They're the people who actually deal with the ordinary people and residents, and probably in best position to know it, certainly as far as the requirements, needs of the areas are concerned. You know, in order to deal with disparities. That said, may I now go on to the...
What I think, Dr. Nice, with your permission, I want to divide it up. So perhaps if we could take a break there, hear the answer to that, and then I'll come back to you on the training issue.
That's fine. Thank you.
Thank you.
Yeah, I'll pick up and then potentially hand on to colleagues in terms of the dental school question. I think that you started with in terms of, or was it not dental schools? That's to come next. Okay, go back to the funding in terms of the preschool work that we're putting in our improvement plan and the funding and constraints. That's why we've put that 6 million aside. That is for the improvement plan only. That isn't to just go into more of the same. That is to really try and make a dent into the preventative measures, the trying to bring NHS dentists back. In terms of the timelines for that, I'll pass on to Dawn and colleagues. But your final one, your other point in terms of how we can do more of that preventing and linking it through general health, that's where we need to engage massively with our public health colleagues, and to form that part of that prevention work that we're doing. And we've got links through PCNs, through our place and through our integrated neighbourhood teams, and it's how we can maximise the value of those when we're talking to the population about health. It's not just physical health, it's talking about dentistry, it's talking about some of the prevention regimes as well. And we'll absolutely take you up on the offer in terms of talking and engaging with district councils. That's we're more than happy to do that through the work that we're doing on the dental improvement plan. In terms of Dawn, Jess, timelines.
Thank you. So this piece of work hasn't yet begun, so we're hoping to start this early in the new year. Again, it will require engagement with the public health team because we want to ensure that we're complementing the work that they already do and enhancing the work that our special care dentistry service already provides. You were asking about workforce. So if our dental providers come forward and say they'd be very interested, we would be using their skill mix. So it would be using the dental care professionals like hygienists or the like, who will go and do this additional work to support, and then they will have oversight and support from the special care dentistry service to ensure that they are delivering it in the best way for patients than they possibly can. I say it needs to be a very linked up approach, and we will start that early new year and that engagement with the public health team.
Great, thank you. Councillor Dr. Nawaz, would you like to come on to your second section of questions around training, please?
Thank you, Chair. We are fully aware that this is not really your remit as such, nor do you have the resources. However, we discussed that given that East Fingland do not have dental school training, although we do have, I think we boast probably, one medical school in East of England. The need is there, and given that the locally trained people who are local residents are most likely, more likely than those who come from outside to train, to stay where they are and provide services locally. And some of them can also be contracted to do so before as conditional offer of a place. So we know that, you know, you may not be the right or the ultimate authority to make decisions or to take measures in this regard. However, we feel that you could instigate, given it does put you in a good position. You know who you are, where you are, what your expectations are, puts you in a position to instigate, and that I choose very carefully to instigate moves in this direction together with the Dean of Peterborough. We've got a brand new university in Peterborough. I'm sure you're aware of that. It's a very good university, excellent facilities. I've had the pleasure and privilege of being shown around. They do biomedical sciences degree, undergraduate degree. They do nursing, they do midwifery and so on. So a lot of the basic facilities are there. And I wonder if you would be ambitious enough to take the initiative to instigate something together with, I mean, I'd be more than happy to liaise in any efforts with the MPs for Fenland, for Peterborough, and hopefully for Cambridge as well. I am sure this would work across any sort of political, party political lines. So if you could host that, I think we would be most grateful to you. We would have our own local dentists, local knowledge, who are more than likely, more than other people, to stay and settle down locally. Thank you very much.
Just to add, Anglia Ruskin University, there's no competition between us.
Yes, it is, Chair.
Anglia Ruskin University also has a very good record in this field, but so the point we're putting to you is, can you instigate something, as Councillor Dr. Nawaz says, and can we assist in any way in local contacts, whether that's Peterborough, Cambridge, or anywhere else? Second one is Councillor Slatter, please.
Thank you. In terms of training, I'd like us to make sure that we have a really good care academy. I'm sure you're well aware of the launch of that. It is still very notional, should we say? And sorry, oh, sorry.
Just trying to get Richard.
Oh, I see. He's masquerading as Maisie, right? Fair enough. Okay. And I am very concerned from my own background for very basic care, which has a great role to play in prevention and just general well-being. So we're talking about a very basic care, like teaching children how to clean their teeth. And that can be done authoritatively by hygienists coming into school, but it also needs to be just general knowledge in a way that seems to have lapsed. So that's sort of one area where if we have people learning how to be, going to the care academy, and we have units there of personal care, that would include mouth care, foot care, hair care. At the moment, they don't appear to be on the list of the UTS offer, maybe because it's not, it hasn't occurred to them, but it's so very basically important. And with my teenage granddaughter, I tell her to look it up on her phone, how to use an electric toothbrush. But it does seem like, a lot of adults don't know how to. So simple things like that, you learn to do it for somebody else, and that the word gets round. So I would be interested to know that we actually keep an eye on those very basic offers. This applies to unpaid carers as well. And we know that dental care amongst those looking after people with learning disabilities or incipient dementia becomes a big problem, even just to get somebody to open their mouth, certainly when they're at the dentist. So good care at home needs to be taught. And if the ICB will come in on the Care Academy with us on those sort of things, I'd be very glad to hear it. And maybe there can be experts from Dr. Nawaz's dental school as well. Just I wanted to really emphasize that basic helping carers to look after people's mouths. It's pretty obvious for schools and things, but for carers, paid and unpaid. Thank you.
Thank you very much. Councillor Daunton, please.
Yes, thank you. I'll keep it short. Are we short of hygienists and dental assistants, as well as short of dentists? And if we are, where are they able to be trained? Thanks.
Good question and admirably concise. And last in this round is Councillor Seif.
Thank you, Chairman. Following on from all of those points, actually, I do have a very specific question. But first, I'd quite like to make a comment, which in a sense, I hope you'll find helpful. And it is simply this, that bizarrely, I have a number of personal friends who are dentists, or more importantly, were dentists. A couple were prominent members of the BDA. And what I heard from them when we were having drinks and so forth is that they had trained, they had done their 4 years, and they were as professional as any others, lawyers, accountants, engineers, but they had the most boring job in the whole world. That was their considered opinion. So as things stand, or stood, they do as much private work as they possibly can and retire as early as they can. And they probably all retired at 50, which means that we're losing that skill and experience. Some of them devised ways of making their lives interesting. One or two of them used to take trips overseas and work in developed countries and provide community dental services to places where there were real challenges. It made their work very much more interesting. I think one of my chums was the president of the BDA, decided that after their 4 years, they'd had the medical training that doctors have, and they should be called doctors, which was a complete nonsense. But that's what they now call themselves, to give themselves the status. But there they are, and they're spending time looking at very basic, for the most part, very basic primary care in dentistry. So following on from the comments that you just made, it would be much cheaper, much more helpful if the dentist got proper training in oral surgery and much more complex cases. Some of them do it, most of them don't. And we had hygienists and triage at the initial visits or the regular checkup visits. It is hopeless, I think, to ask dentists to just spend 5 minutes just seeing if somebody needs further work. And in fact, sometimes I got an idea that they even invent that work if just to keep themselves busy. Well, perhaps that's not fair on dentists. So my question really is, how are you going to make, or how can we all make dentistry a much more attractive profession? How can we use the resources that we have? Do we have the power? I mean, you referred before to the need that the practitioner has to be a registered dental practitioner in order to provide dentistry services. Can we not restructure it in such a way that the hygienists and other carers or oral health carers can provide those triage services and then refer up the more complex cases to their dental colleagues? And that might save us a lot of money, and we might get a better service, and we might get dentists to remain in post for longer. Nikki.
I'm sure there's a joke in there from an accountant about the most boring profession being dentistry, but I'll move on to answering the question instead. I'm going to hand over to Dawn, because actually the majority of these things came up in our 3 engagement events with the dentists. So it's really good and positive actually that the things that you're raising are conversations that have come to us via dentists and that profession itself. I'll make 2 quick comments though. One is around the Care Academy. Absolutely, dentistry should be in there. You know, just tell us who we need to speak to. That's an absolute, feels like a real win from our perspective. The dental school, I know that Dawn will touch on some of this stuff. As much as I would, and I'm quite happy to rip up the rule book on quite a lot of things, it's in the remit of Health Education England in terms of that. So it very squarely sits with them, not with the ICB. That doesn't mean that we can't initiate conversations and to put that out there, but it does, that specific responsibility does sit with them, but there isn't a reason why we wouldn't engage in some of those conversations. But I won't steal Dawn's thunder. I'll let her pick those up.
Thanks, Nikki. So as previously alluded to, as part of taking on the delegation of dental services, our first priority really was to start to build that relationship with our dental providers across Cambridgeshire and Peterborough, and to predominantly understand some of the challenges that they're facing in their ability to deliver NHS dental services across our patch. It will come as no surprise to learn that they're facing the same challenges as general practice in terms of workforce, recruitment, retention. Given the constraints of the NHS contract and the lack of funding in place to support some of that, it's generated a lot of pitfalls in terms of them retaining staff and being able to offer that career progression to individuals that are working in the practice. Hence, there is that bigger move or sway towards delivering private dental services, which are a lot more lucrative in terms of funding. So what are we doing locally to try and address some of this? So we have engaged with our the Health Education England, so the dental colleague from there, to help understand what can we do locally to try and open up the opportunity around education and training for dental staff across our patch. Again, some of the biggest issues coming out of our conversations with the dental providers is that they have some workforce, but there's no career progression. A lot of them have done their training, but they're not actually funded to undertake some of the tasks that is within their gift to deliver. And so it's a wasted resource to some degree. Trying to retain them then in a role where they can't exercise that degree of professionalism and competency that they've trained to do makes it even more challenging for them. So we are looking at what we can do locally around a dental school, looking at space. I believe there was one historically, and Jess will know the detail, some space that was offered through one of our acute providers to enable some of that to be delivered as a spoke of, I think, the Essex unit. In terms of recruitment and retention, again, our ambition as part of our wider ICB workforce strategy is that dentistry no longer becomes the forgotten relative, that we actually include that as part of our wider workforce strategy, so that dental and community pharmacies and optometrists all form part of that ambition going forwards. We have supported careers events to try and reach out to the future generations, to try and make it an attractive option for them, for dentistry specifically, to engage them in some of these events. And we are working collaboratively with all of our dental providers to raise the profile of the profession locally. Are we short on dental assistants? Again, we don't have the same level of information that we've had historically for other primary care providers. So for general practice as an example. So part of what we're doing is to understand the workforce landscape, what exists and where, and whether we have the right skill mix to be able to deliver on the needs of our population, where they need to be delivered from. So I think we are making inroads, but I think it's fair to say it's been an understanding and scoping exercise to understand some of those challenges first and foremost. Jess, is there anything you wanted to add?
Yes, just further to add around the really helpful comment that was made around using hygienists or dental care professionals. So as part of the reforms in 2022, for the national team, it was very keen to start utilising the skill mix. So at that time, dental care professionals could open and close a course of treatment. They've now gone one step further and allowed them to actually submit their own FP17, which is how we obviously get the patient charge revenue and the information around patients. So that certainly there is a huge push to use the whole skill mix, exactly as you said, so the dentist can move on to doing more difficult treatments, and the hygienist and other dental care professionals can learn further elements of their area of work.
Okay, time's running on, so I'm going to roll together prevention and local provision. So I'll just indicate to the members, this is the last, not necessarily the last round, but the last section of questions. Councillor Van der Ven first, please. No, not first, she's not quite ready. So who wants to go first in this section? Councillor Boulat, I see first, then Councillor Wilson.
Thank you. I had just a brief question, which I think it relates more to staffing, but then I will go on to the local provision, because I've seen that it's currently under government consultation to make it easier for overseas dentists who usually, well, so far had to go through quite a lengthy registration process, and there's some new proposals currently under consultation to give the General Dental Council more powers to provisionally register dentists so they can deliver care a bit quicker. So I was wondering if you see this kind of consultation, depending what the result is and whether this is implemented or not. Of course, it's still under consultation, whether we have to be aware of any potential impacts, both in terms of whether if we're registering easier dentists, whether they will need additional training locally, or whether this will in any way could address some of the staffing pressures at the moment as well. But on the issue of local provision, just wanted to say that, well, as a council, we passed a motion recently with cross-party support on NHS dental access. So it's clearly like a very big concern for many of our residents. That's why we ended up debating it in full council. And one of the issues we discussed about is around how we can engage better with patient groups. And I've seen that you've done a lot of this work in the recent months since you took over the dentistry. So it's really positive to see that. And I would like to share just a response, because I shared this paper before, after it was published in our committee papers, with a local group that worked with me on the motion that we put to council, which is part of Toothless in England, who are of course doing a campaign around the dental contracts and many other things as well. And just want to share with you all today that they really welcomed the news and the report today. And I just wanted to read a little bit of what they said and ask if you have any response, because many of them are actually local residents, because they have some local groups in Cambridgeshire as well. So they're saying that they really welcome the news that the ICB secured the 6.1 million of funding to help improve dental services. They would also welcome a timeline for instituting those reforms, because they're really concerned that day by day patients are losing more access. They're saying that of immediate concern for them as a group, they're the children, people who are vulnerable, and people who are in most urgent care. And they continue saying that on this basis, we do urge the ICB to consider mobile dentistry sooner rather than later into the communities, especially the rural communities that most need it. However, they do say in their statement that was sent to me yesterday that they reiterate their call for government to reform the dental contract and asking us as councillors sitting on various relevant committees, how can we put pressure, if in any way, on that, because in their view, that is the kind of one of the main issues, really. So yes, I think it's really important to engage with groups that have lived experience. I just want to read this out today so they have, you know, a voice in this debate as well, and ask if there's any kind of response on some of the points that they make. Thank you.
Thank you. Next, Councillor Slatter, please.
Thank you. My question is about the orthodontists. You say in your plan that your additional resource will be offered to reduce the waiting list. Only yesterday, a resident was reporting that it was only the one orthodontist in Cambridgeshire that she'd been able to get hold of. Made an appointment, couldn't get there in time because of congestion in the city, and was not allowed to have the late appointment. So for one reason or another, even those providers are under pressure or even reluctant, I suspect. I see that we have 6 orthodontic contracts across Cambridge. So presumably this is an area where there are some contracts waiting to be contracted. So I'd like to know whether you've got any plans for that particular bit of local shortfall. Thank you.
Thank you. Councillor Daunton, please.
Yes, this is a local provision question. 2 parts. The first part refers to new developments and Section 106 monies. We talk about GP services on new developments, Section 106 monies. Are we also looking at dental practices and the possibility of putting NHS dental practices through the Section 106 process? And the second question is, you referred to community spaces, the possibility of using community spaces. I just wondered how that works and whether, in fact, there might be some conversations with the County Council on community spaces.
Thank you. Councillor Van der Ven, please.
Thank you. 2 questions. One is about the use of community hubs and oral health education. I know we were talking a little bit before we started formally. I could have asked that question about child and family centres, but community hubs are going to be more prevalent. Child and family centres are not consistently provided across the county. The other question is, could you give us your views on fluoride in the water, and what my understanding, it's very variable in this country, having grown up somewhere else where there's more fluoride in the water. Could you give us a steer on, you know, what kind of pressure you think needs to be brought to bear in a reasonable way, if you don't mind? Otherwise, I'll ask you after the meeting.
Okay, this is the last chance for Councillors Black, Organ and Dr. Nawaz. Oh, good. Right, I'm going to write it down so I don't miss people, if that's all right. Could you just keep your hands up for a moment? Okay, I've got 4 more speakers. That is now closed, but we'll take all of those. Councillor Dr. Nawaz first.
Thank you. Coming back to the answer you gave, is it? I mean, you've said that you have you've made contact with health education. Could you be a bit more explicit? Could you elaborate on what sort of contact, what sort of responses you've had, what sort of timeline you have? And also, do you not think that possibly, given that local MPs would be keen to get involved, this may catalyze, or to use expedite, probably a better word, to the whole process, which would stand a greater chance of it being implemented quicker than otherwise might be the case. On the overseas dentists from overseas. Now, there is a program with the GPs. I'm sure you'd be aware, the IGPR recruitment, which entitles practices to, I think they have licenses to issue visas for up to 4 years. And I believe there is one still under that training program in Peterborough that ICB are supervising. Now, a similar thing is being pushed by one of the local MPs. Now, I'm keen to keep this across party. I don't want to get into party politics with health, dental, or general. Therefore, I'm not going to name any names. But there is a keen interest in expediting the process of bringing in dentists from overseas without having to sit the local examinations. But I think there is an almost inherent risk in that, because the training standards in different countries are different. Their clinical culture is also somewhat different. Therefore, their expectations may not be similar to the expectations that we have with our patients here. Therefore, although it may be a temporary plaster application solution, I would go back to the original suggestion that which this colleagues we discussed about the local training school. We think that would be the proper permanent answer to our local needs. Thank you.
Thanks. And there's obviously a deep question there about international recruitment that we can't do justice to today. There's no reason why we can't revisit it in a future session. So feel free to comment briefly on that issue, but I think that's not the main focus of our debate here today. Next, we have Councillor Horgan, please.
Thank you, Chair. I apologise up front. Building on your earlier attempts at humour, I wanted to drill down, pausing for puns, into the dental improvement plan that was in the report. And there was just 3 areas, I know there's a lot there, that I wanted to understand a little bit more about. That was the child-focused dental practice initiative. That's the first one. The second one was the care home staff support offer. And the third one is patient engagement. I wonder if you could just speak to educate us a little more on those 3, what they look like. Thank you.
I like bad jokes, by the way. So my old mum used to say things come in 3s. So we've had a joke about accountants, a joke about drilling down. I'm looking for one more bad joke before we finish, okay? Second? We're going to be filling in our time. That's so bad, it doesn't count. Councillor Costello, seriously, Councillor Costello.
Yeah, thank you. Yeah, my question is a little bit about a local issue, but also the future of dentistry. It seems to me that this plan is like catch-up, trying to sort out the mistakes of the past. And we are demographically a growing population, and we do need dentistry care for a long time, from 0 to some people are living well into their 90s now. And it does concern me that I see it in my own ward of Ramsey and Bury. We've had so much housing development, and there will be a further 500 houses in Upwood, just up the road. And we've got 1 dental practice and no plans for anything else, which results in people having to travel to other towns to receive treatment. So my question really is what are the long-term plans for dentistry in local areas?
I've got one more speaker and then there'll be the final set of answers. Can I just give notice to Caroline, before Nikki comes back with the final answers, I'll just ask you to add anything that you want to add, having listened to the debate. But the last member speaker is Councillor Wilson, please.
Thank you, Chair. I wanted to refer to the Health Watch report published in February this year, which includes a lot of really good stuff, but particularly this sentence: some people have told us that their dental practices won't see children on the NHS unless their parents sign up with the same practice as private patients. So I'm interested in the ICB's view on that, that if you do manage to attract some NHS dentists, will you insist that the whole family is signed up, not just children?
Great point. Caroline.
Thank you. Yes, so everybody, I think it's been distributed, the Health Watch England position on dental access, which really mirrors very much what we're hearing on a local basis, pretty much exactly. Even the fact that it's consistently the second most prevalently asked about issue locally after primary care. Some of you may be aware that just before the pandemic, in 2019, we published our own dental report as well, which is still quite widely circulated, where we went into, we used our powers of entry and enter and view, which Health Watch has, to go into local dental access centres, providing urgent treatment for people who've got an urgent dental issue, not to find out what people thought of the practice, because actually we'd had really good feedback on the dental access centres, but really to say to people, why are you there? And clearly the reason was that they were unable to get a dentist, and we heard of people who, as we've just heard, their children were able to be treated but not parents. So the issues that we found at the time were very much the same. We were also able to highlight in the report as well the fact that, having obtained some figures from North West Anglia Foundation Trust around A&E attendances for people who had severe dental discomfort, people who turned up at emergency departments with this, there was some temporary funding, an additional amount of funding injected over a period of 6 months into the dental access centres. And we were able to demonstrate a direct correlation between people being able to actually access that care in these urgent times, when that funding was in place, as to when it was withdrawn again. So I do just wonder whether I see the fantastic proposed initiatives under the dental improvement plan. I just wonder whether there's anything staged. Lots of these will take some time before the effect is felt. But I just wondered whether there might be any interim measures where we might be able to, I don't know, play catch up to some extent, or at least improve people's access to urgent care where they need them, ahead of us being able to do things like bring out dental vans and so on. So it would just be very interesting to know whether there's any ability to be able to be a bit creative and release funding, amounts of funding perhaps ahead of time, to be able to address some urgent care, just so we're not playing as much catch up when we do have, hopefully, some success with the new measures being brought in.
Thank you. And final round of answers, Nikki.
Yeah, so I think we're going to. I'll go through the questions and I'll bring people in as we do that. In terms of, I think the first one was overseas dentists and recruitment. Obviously, the government are out consultation on that. They're doing that work. Will be supportive of any measure that comes through that increases the dental workforce and the time for dentists to get into practice. And I think actually, because we've got the local engagement, it will help as we start to bring those through. So what we've seen when we've done this overseas recruitment in terms of nursing in particular, they are retained when they create that sense of identity within the community. And it's by being able to create that, I think that will be a real key for keeping them here, because otherwise what you find is they come for about 6 to 12 months and then migrate to the bigger cities, London and Manchester and others. So I think for us, the key bit will be the fact that we've got the engagement with the local practices, and we also have established links through our neighbourhood teams, which will be able to then create that sense of community for any of the overseas recruited dentists, fingers crossed if they do come through. In terms of timelines for our reforms and our dental plan, I'll just pass over to Jess and Dawn on that one. I will say in terms, I think one of the parts of that question was about how we can access and how we're going to address children and our most vulnerable population. I think one of the things that we've seen in terms of children, Cambridgeshire isn't the worst in that area, which over the data that we've got at the minute is still a year out of date, but for 22-23, 51.3% of children, 51.3% of the population of children had seen a dentist within the last 12 months. That puts us 21 out of 42 ICB. So we're not, we're definitely not by far the worst in that position, but you're very right in terms of the most vulnerable and the work that we're doing, particularly, as I said, with this company that's working with us to look at how we can maximize, whether that be payments or whether that be the work that we do with dentists. We are looking particularly at that geographic picture of dentists. We've finally got that plot for how far, and I'll come on to it again when we talk about the councillor from Ramsey as well, how we address that in a longer term plan. But Dawn, on the timeline.
Thanks, Nikki. So we've already rolled out additional capacity with our high street dentists. So any provider that's offering NHS dental services has been offered the opportunity to increase dental provision, as well as increasing, obviously, the proposal to increase the tariff price to make it more attractive opportunity. When we look at the new dental recovery plan, as Nikki's already alluded to, it sets out how we're going to drive forward those major new focus on prevention and good oral health in young children and deliver an expanded workforce. So I think by tying that into any investment that comes down, looking at how we can build that into our workforce strategy going forward, linked into international recruitment, etc., will help us to expedite that quite quickly. In terms of plans to address the growth and the provision of dental services around that growth, there is an opportunity for us to look at any Section 106 funding that does come down. Predominantly, when we talk about primary care, it's been interpreted that that means general practice. Obviously, we're in a different landscape now that the ICB has taken on that delegated responsibility, and we want to provide parity across all of our primary care provision, which includes dental as well. So we need to make sure that we focus and include that in our planning assumptions going forward. In terms of the use of community hubs and dental provision, absolutely. I think that's an opportunity. And again, working with the stakeholders, both from general practice and through dental providers, there is a definite appetite to work more collaboratively together, both to tackle the urgent same-day issues that may be presenting also through general practice for dental issues, and look at opportunities around management of long-term conditions through dental providers as well. So expanding their knowledge and experience, but also making better use of the workforce that we have within our wider primary care family. So Jess, in terms of timelines, I'm going to hand over.
Thank you. Yes, so we've already offered out the mandatory services. So certainly in the north of our area, so around Fenland, we have got interest, which is absolutely great. So yes, as soon as they have been finalised, we will be able to start those, and our hope is to be able to begin that before the beginning of April. Similarly with orthodontics, as you mentioned, Councillor Zeta, there are 6 to 7 orthodontic providers, so we will be offering this funding to all of the orthodontic providers to help try and release and reduce some of their waiting lists. Just on orthodontics, it's a referral only service, so it might be really useful to pick up the query that you raised outside of the meeting, and I will certainly have a look into it, because we are not aware, I certainly haven't been aware of any issues of access issues into orthodontics, although there is a finite provision, and they're very amenable to supporting patients. So I'm more than happy to pick that up and have a look at, absolutely. In terms of orthodontics, We have putting out a request to extend their contracts for further 3 years. We are trying to ensure much more stability into orthodontic services. As councillors may be aware, there was a national procurement a few years ago. And unfortunately, in our area, that was not successful. So we have rolled over contracts, which is not the most viable solution for our orthodontic providers or our patients. And so we're using this next set of contract extension to really look at the need across the system to ensure that we are putting the best service in place for our patients. So we'll be doing a lot of engagement around that as we come closer. As part of that, we were being asked around the child-focused dental practices and care homes. So with the child-friendly dental practices, this is based upon a pilot that the Eastman undertook, and our regional paediatric managed clinical chair works within the Eastman and was very keen across the east of England and other areas across the country to see about piloting this piece of work. So at the moment, what we have in the system is we have general dental practices who may have an interest to support young people, and then we have the special care dentistry or community dental service, and the patient jumps from one to the other, and then very sadly, very quickly into secondary care dental for general anaesthetic. So the idea and solution around this is to train general dental providers or high street dentists to enhance, and their therapists to enhance their tier 1 paediatric skills, to try and prevent and support patients to be seen quicker and a more timely way, and not then ending up in hospital because they couldn't be seen. So this then aligns with Core 20+5 around the reduction of general anaesthetics in under 10s. And so we're working really closely with the paediatric MCN chair as a subject matter expert and other colleagues across the system to ensure that we've got the best possible solution in place. Because we want to make sure it's so robust and it is the right provision, it will take a little while to set up. We've just received the evaluation from the pilot that was undertaken in Norfolk and Waveney that has been shared with us, so we will be learning from that. It probably will not be called child-focused dental practice, and this will be an additional service that our high street dentists will be providing, but the name change will probably come. Just with care homes, so this is a initiative that we did undertake when we were in NHS England, and we want to continue. And it began as an oral health promotion support package. So it was led by dental care professionals working with support from our special care dentistry colleagues to upskill care home staff with their oral health care needs of patients. It was really successful. There wasn't an abundance of care homes involved, but the group involved, there was a really good evidence base to carry this on. And the next step that we wish to take with that is to look at the treatment for patients. So if it's identified they have a treatment need, that they have an identified dental practice to go with too. That will then obviously link with the work that medical side, primary care already do, and already linked into the care homes to make sure we've got a really holistic pathway in place for our most vulnerable adults. And again, I need to ensure that we link up with the wider work that's going on. So certainly beginning of next financial year, we will start to see that take shape, and we can certainly bring back further information around that. And as part of all of this, patient engagement will be paramount. Working internally with colleagues who have the patient engagement need, we will ensure that, and working with Healthwatch, that we are really reaching out to patients to understand if this is the most appropriate way forward, and if not, what changes and developments we can make. And I think there was just a question around fluoride. Do you want to take that one, Nikki?
Yeah, can do. So I'm just trying to skim my notes to make sure we pick up everything in terms of fluoride. This is led by the national team. There's a lot of research that says if you put fluoride in water, you'd be able to reduce the levels of decay in teeth and therefore the number of tooth extractions. So I think they're building on the back of that. We know that nationally it's subject to consultation. There's a programme of work that would enable an additional 1.6 million people to benefit from water fluoridation, but it's first expanded across the northeast, so there's no timeline yet as to when that will move further down the country, and I'm assuming they're using it as a pilot to see. But the problem is with some of these things, prevention, the outcomes take much longer, don't they, in that space. Health Education England and expediting them. I'll give you their number. I'm more than happy to expedite any conversations with Health Education England. So yes, we'll quite happily take on any level of support, names, championing as possible in that space. It is definitely something that we have had a number of conversations with them about, and how we can, as I think Dawn and Jess alluded to, there was provision in that space, and one of our providers has offered up space as well, because it will benefit them having that flow between primary care and secondary care, and those expertise. And again, that could help with your learned friends opportunity to keep dentists more engaged and less bored if they were doing some more of the specialized work anyway. In terms of I think the other parts were about the longer term plans, and is this just a sticking plaster? I think that I'd go right back round to where I started, which is the work that we're doing to look at our get real data into our dentistry provision at the minute, because what no one's ever been able to answer is, are there enough dentists? Because actually we might have enough dentists, it's just that they're not enough NHS dentists, and how we use them. So I think that piece of work will be really critical, and where we then focus our money and focus the improvement will be in the areas where it's got the most most deprived in terms of that dentistry provision, not necessarily aligning with most deprived populations. So in terms of our shining lights in terms of dentistry provisions around Huntingdonshire, which is not one of the most affluent areas, but does have a very good dentistry provision for both adults and children, and we get regular take-ups and activity at those levels. So when you talk about dentistry, it might not be the same in terms of access and deprivation when we're talking about general practice. And I think that's the bit that it's going to be really interesting, getting this data back and that insights piece of work, and also challenging the question of, if you were to use finances and put a different tariff into what nationally their current contract says, would that change it? But I think from our conversation engagement with dentists, it's a double point. It's not just the money. It is absolutely about doing some of that either more specialist work using the MDT approach, and a lot of the, when we talk to dental nurses, dental hygienists, they would stay in the profession if they were able to go out and do some of the school visits and do much more of that community work. They'd find it much more engaging and much more beneficial in terms of careers for them. So I think one thing I would ask people to take home is, we do have some really, really engaged practices on this. I think that they felt like they haven't been listened to because they were part of a national machine. So hopefully the benefits of this coming down locally is that we're able to take that feedback and determine a local plan that will work for our population and the dentists that are within that. I'll echo Dawn's point and bring it into your longer term plan question. It's not just about vans. You know, vans will help us for a little bit in terms of that rural provision of dentistry service. It is massively about those integrated neighbourhood teams and community hubs and that space. Because I don't know, well, I'm assuming you all probably know, Section 106 money takes forever to come down and it's very small. I'm sure you don't have to pick up a newspaper and look in terms of Northstowe or Alconbury Weald or any of the ones that we're in areas that we're talking about. So it doesn't cover it enough to build a GP practice and a dentist practice and community services. So how can we co-locate those in one space so that they dentists can effectively travel around it? It helps in terms of your capital costs, that you wouldn't have to then have that provision, or you know, they'd be able to access the equipment rather than having to effectively bring that along themselves. So I think that for us it is much more about that new models of care. How do we engage populations to do our population to do and determine their own health much better, and educate them and bring back some of the things that maybe have been lost in the last however many years, allowing the NHS then to use its specific specialised money for the people that then should be accessing secondary care, not what is happening at the minute, whereas particularly in children, the number one treatment, secondary care treatment for children is tooth extraction. You know, we can't surely live in an age where that's still real in the next 2-3 years, and the way to do that is absolutely through some of that prevention piece. I think that was all of the questions, but I'm sure I may have, in the 11 that I counted, may have missed one or two. Yeah, go on.
Got
So-
13, but I know also that you've very kindly given us more time than we originally said, so I'm going to bring it together now. Can I just remind members of the committee that as part of our reform of health scrutiny, it's agreed that we would work on getting the results more clearly published and forwarded. So I just commit again to sitting down with Rashenda, and we will write this up to do justice to the debates that we've heard today. And Councillor van der Van and I will agree the final outcome, and hopefully it will reflect what the committee wants. I would just say I'm not going to therefore do a massive summing up, but I will summarise some of the major areas. I think we're likely to want to express concern about the difference between the new money announced and the actual fact that a lot of it is new money, and there's still a huge difference there is between the minimum activity payment and the private fees that dentists can offer. I think we'll probably want to welcome the extra money that the ICB has already committed to dentistry, and to its work with on a health economics approach, both to deal with issues of deprivation, but also to deal with the tariff and what actually is going to work. It's not going to be easy, all of that, but I suppose we'll probably encourage you to move as quickly as possible to assess the sufficiency and then make some decisions and to share them with us. But I think we would want to welcome that. On the oral health promotion budget, I would imagine we'll want to welcome what you said today about maintaining and giving uplift to that. And we'll probably want to encourage you to speak as fast as possible to each other with our own public health colleagues to bring as much clarity as that as possible, and even possibly to in principle say we want it extended beyond 2026. And we'll probably want to welcome what you've said about the work with care homes and want to encourage that to continue as well. On the training and employment issues, whether we use the word instigate or catalyse or whatever, I think we've heard a very strong push. We know the number of health education in England, don't worry, but I think you're being asked to collaborate with us and us with you to be much more active in not just telling them, but seeing what we can do to lobby and push and advocate to try and get more dentist training. And there's the important point raised by Councillor Statter about also the link to the Care Academy. What I would say to you about that, particularly Nikki, we're interested in collaboration between the Care Academy and your workforce strategy generally. We've encouraged our officers to collaborate with you. It's not one initiative, but they're, where we can have cooperation and complementarity, it seems to us to be a good idea. And that's not just in relation to dentistry. So we'd really like to encourage your workforce people to look at that with us and vice versa. We heard the points made by Councillor Seif to, I think, welcome the progress made so far to allow dental assistants and hygienists to do work to increase cost effectiveness and make dental jobs more attractive. I don't believe dentists are bored though. And I think your point at the end about offering more community work as well to those functions to make those jobs more attractive, all of that is good stuff. Without prejudicing possibly a later discussion about international recruitment, having clarity around the registration details around international recruits and advancing local training as suggested by Councillor Boulat, I think will be on the list. This isn't in principle one aimed at the government or at you, but without reforming the dental contract, it's difficult to see radical changes, and I think it's probably honest for us to say it. And then in the final section that dealt with prevention and local provision, I think we'll probably want to welcome the fact that you've offered to meet Councillor Daunton outside of the formal meeting about access to orthodontists in Cambridge in particular. Obviously encourage that. We had a discussion about Section 106 and new developments. We had the call from Councillor Costello about a long-term plan on that, and I think there is an interaction there with planning policy with our district friends. But there was also the point made at the end there by Nikki about integrated neighbourhood working and seeing this as part of the agenda for integrated neighbourhood working, that I know Councillor Van der Ven and myself would strongly welcome that. Including collaboration with the County Council on community spaces. We've got our own plans around that, so we should be collaborating around that as well. On fluoride in water, I suppose we'd push you a bit harder to say, what can we do locally to advocate to national? Okay, it's their decision, but we think we want it. And if you can agree with us, let's campaign and advocate together for that to be the position and for us to go up in the queue. On this shocking finding from Healthwatch about dentists insisting on private sign up by parents for their children to get NHS treatment, we should express our shock about that and call on you to prohibit it in contracts. It's or in the funding that you give. It's completely unacceptable. I think we should. We've heard what you said about high street dentists, but we've also heard what Healthwatch has said about urgent catch-up and further temporary measures. So it makes sense for us to ask you to further explore that. And I think we should welcome what you said near the end about training on advanced paediatric skills to the high street dentists. I think that clearly is a good initiative and can improve children's dentistry. So I imagine we'll want to welcome and encourage that. So, but I'll sit down with Rashenda and we'll get that formally written up. We'll forward it to you as soon as we can. And it will obviously be agreed with Councillor Van der Ven. Councillor Van der Ven, did you want to add anything to that?
Thank you. It was such a good session. We really are very grateful. I think it's been far more instructive than our earlier scrutiny sessions, and we just understood how bad access was. So you really helped us a lot with our understanding. So thank you. I just wondered if I were to see a poster on a bus stop or a bus going by urging a young person to embark on the career of an NHS dentist, what would the few words on that poster, what would the enticement say? Why should I become an NHS dentist? But I think that's a very simplistic question and maybe not fair, because you've given us, you know, a lot of layers of understanding about how these things knit together. But still, we don't have, I'm not aware of any kind of public campaigning on, you know, why go into this career? It's important. And you did talk a little bit about the incentive of working in the community and the rewards there, but what's your message?
And I think that's an excellent way to end the hearing. So just before I invite you to answer that, can I formally thank Nikki Briggs, Dawn Jones, Jess Bendon, and also Caroline Tyrrell-Jones for all being present with us. I also think it's been an extremely constructive session, and I will happily give the last word and a good response to Councillor Van der Ven's question to you, Nikki.
Thanks, and I'm going to take zero credit for this and give it to Dawn in terms of her slogan is "Help the nation smile again." So I think I'll leave with that one as how we'd pitch it to the next NHS dentist. But in that place, the ICB has taken up both days in terms of the schools careers fair, and so the Cambridge, so it will be hopefully prominent there. There you go. We might get it on, not on the back of a bus, but maybe on some kind of poster. Councillor Van der Velden on that. Help the NHS smile again.
Thank you very much. And we may be smiling, but not at the quality of jokes that have been expressed this afternoon, folks. Thank you very much to all of you. I'm going to move us straight on. So obviously you'll just take a few seconds to leave, but for members, can we move straight on? Because we're obviously now running behind. We're going to move direct to pages 245 to 248, 13 quality accounts, and Rashenda is going to briefly introduce the report.
Thank you, Chair. So as members are aware, the 6 largest local NHS providers are required to provide a quality account each year to provide assurance around the quality of their services. That's measured primarily against patient safety, the effectiveness of treatment, and patient feedback on the care they receive. Trusts are required to provide a copy of their draft quality accounts to their local health overview and scrutiny committees for review and for comment, and also to Healthwatch. There's no requirement for the overview and scrutiny committee to comment, but where they do, their statement must be included in the published version of the quality account. Draft accounts are usually received around mid-April, and comments are required between mid-May and early June, so that doesn't align with committee meeting dates. To manage this, last year, officers recommended setting up 6 working groups comprising of members of the relevant liaison groups to review and respond to the draft accounts in consultation with the committee spokes. Partner governors were also invited to be part of those working groups, and other committee members had the option of joining. We're recommending the same process again this year, although for practical reasons, we do suggest keeping the working groups quite small because they do need to meet quite quickly. Thank you, Chair.
Okay, it worked really well last year with Rashenda's support, I have to say. That was excellent. But this is an important function we have of our health scrutiny function. Our findings get published. And so the members who are already engaged in the liaison groups have expertise and knowledge. It's probably only one meeting and probably an online meeting, so it doesn't have to be time consuming, but you do have to put your heads and thoughts into this in that meeting and not just leave it to Rashenda. She'll help us with some thoughts and ideas, but you really do have to add to them in those meetings. But everyone did really well last year, and we're asking you to do the same this year. The second thing I'll just say is this, and I promised to say it this morning, particularly to our district representatives here. I think 2 of you already serve on the liaison groups, but they are all open to our district representatives to join. And so each acute hospital and each health trust within the county, we have a liaison group with. And if within your area or within your area of interest and expertise, you would like to serve on a liaison group that you're currently not doing so, there are no restrictions, for example, on numbers or party balance or anything. It's an open, these are informal and private meetings, so there's an open membership. And so particularly to our district and city colleagues, can I just ask you, and I'll ask Rashenda to resend to them, our COPTs, the list of full groups. And if you would like to volunteer to join any of those groups that you're not currently a member of, we would very much welcome your participation. So obviously one of your first jobs here will probably be to participate in the quality account, which will be a great learning experience as well if you do join one of the liaison groups. So I just wanted to accentuate that now at the start of this debate. I think this is probably fairly uncontroversial in terms of the process, but I'll just halt there in case anyone wants to ask a question or to put a point. Councillor Wilson is the first.
Thanks, Richard. So three things I'd like to see in every report, and I think there could be some useful common wording on these. One is waiting lists. Secondly is lack of funds. And then third would be links with the county council and the extent to which they're working or not working. I think in many cases they could well be improved. Thank you.
I have to say, Councillor Wilson did raise this with me in advance. I have to say they're really pertinent points. I'm hoping they'll appear in the minutes if that's possible, because I think they're very, very pertinent points. And from the chair, I would support that. Councillor Slatter.
Yes, and one might add staff recruitment and retention, because that also brings out the commonality of a lot of these things. I was just going to ask, I'm really glad that we're opening this up and emphasising it. it may well be that there are district and city colleagues who have a particular expertise who might be able to make that contribution just the once rather than seeing it as a lifetime commitment. So if there are people that we know think, oh, that particular councillor could really help with this particular trust on this particular topic, that would be good too, if that's allowed. And that's what I'm looking to Rishenda really, whether you're prepared to have sort of people coming in and out of these lists.
Yep, they would have to be appointed temporarily to the liaison groups, but Patrick has delegated authority to do that, yeah.
It's obviously your most serious responsibility, Patrick. I'm sure you stay awake at night worrying about that deep power that you have at your disposal. Councillor van der Ven.
Yeah, just for those who are not already participating, the exercise, it's called quality accounts, but it's not looking at their accounts. It's looking at it sort of a general, it's almost like looking at annual report, and it's very public facing, really user friendly. And I found it a really good way of actually getting acquainted with the different NHS trusts. So it's a good introduction. And then you can then you can do more if you like. Thanks.
And that's a very helpful clarification. I perhaps could have introduced it better myself. I completely mistook that 3 years ago. I thought it was finances, and it's not. It's the service and how good they are or not, and what they say about that. So that's a very helpful clarification. Thank you, Councillor van der Ven. I saw another, yes, Councillor Seif.
Just to add, I don't want to add too many things to what the quality reports might contain. But the thing that I always would ask and have asked when I've been on these groups is what special issues does the trust face, either in prevalence of a particular type of health condition or in their day-to-day operations. And I think that they do actually reveal different characteristics. And I'll give you an example of something, but that's one of the issues that I would like to see highlighted, that we always look at when we talk to them. Just a minor thing, I noticed that on the Cambridge University Hospital Trust, I've been sitting with Susan Councillor van der Ven on the research hospital, the University Research Hospital. So I don't know whether you want to put my name down on that, or I shouldn't be on it officially. The research hospital.
I don't think they're doing an equality account yet because the hospital's in development.
Oh, I see. Right, yeah. Because it's still being developed. I see what you mean. No, not the Research Institute, the Cancer Research Hospital. But we've had meetings, a meeting, and we've got one coming up, have we not? Yes, but it's different. Sorry, you're right. Different type of liaison meeting.
But you're first in the queue where we do have a quality account from them, and we all hope that they advance so well that won't be too far away. Okay, the recommendation, I suspect, is to note the report. Oh no, is there a set of recommendations? Am I reading it wrong?
Yeah, we need the committee's agreement to establish the working groups in the membership, please.
Okay, formally it's my job to read that out, and I haven't done it, so you just have to bear with me while I do so. We are this is for the people who are watching online, so you please understand that. The committee has recommended to establish 6 working groups to review the draft quality accounts for 23-24. B, agree that these working groups consist of the members of the relevant NHS provider liaison group. That's any additional members agreed by the committee, and we're delegating that to Patrick today with an open invitation to members. Partner governors appointed by the committee to NHS providers will also be invited to join the relevant working group, and that we delegate authority to the Democratic Services Officer at the direction of the working group in consultation with the spokes. So that includes the Conservative spokes as well, I should add, to submit the committee's statements on the 23-24 quality account. So after you've met as working groups, the spokes will agree the final submissions, so we don't have to wait for the next committee, and they can all be done in time. For the co-opted members, this is my practice, which is if you're happy with that, nod, and if you're not happy, shake your head. I see a hand. I don't see nods, so I've got to ask you to put your hands up. Those in favour of those
I have a
recommendations?
question, actually.
Oh, a question. I'll just take that first.
Yeah, thank you. I'm a little bit unclear about these groups. Are they just to do with accounts, quality accounts, or are there different sorts to take care of various other aspects of the trusts?
Right, the quick answer is various other aspects. The second one, they meet 4 times a year on average. They meet in private. They're small, and they enable discussion between members who are interested in that health unit and the senior people from it, in order to increase mutual understanding and to inform our health scrutiny work. And so, of course, some things can be said in private that can't be said in public, and it enables a relationship of trust to be built up as well between the members and the health provider. So it's not just for the quality accounts, it's a continuous role, but I'm first to accept what Councillor Steve said. It's not one for a lifetime.
Yeah, thank you for that. Very helpful. Did I hear you say that you would be circulating a list of these groups?
Yes, I'll ask that specifically to go to all the co-opted members.
It's in the paper.
And it's in the papers, but I'll ask it to come around as well, which will be a nice memory prompt for you afterwards. Okay, I'm now just going to have a quick vote because time is moving on. Those in favour of the recommendations I read out, please show. Those against? Right, that's unanimously agreed. I have to drive us on, folks. Just to say, I'm going to ask Rashenda to briefly introduce the next report, but I'll then ask Councillor Daunton and Councillor Costello to briefly comment, who kindly engaged with us on the work of the rapid review of the Integrated Care System Winter Plan. That's item 14. You'll find the report on pages 249 to 254. And again, Rashenda, if you could briefly introduce it. Thanks.
Thanks, Chair. Very briefly, the committee will recall you did have a report come on the ICS Winter Plan, but unfortunately the report presenter was unwell and unable to attend. Decision was taken to establish a rapid review group so the committee could progress that work. The group met with the Chief Executive of the ICS and the Director of Performance to put the committee's questions to them and pursue their own lines of inquiry. Their findings and recommendations were shared with the committee spokes and were sent to the chair of the Integrated Care Board. The reports included purely for noting to place it in the public domain.
Thank you. And before I bring the members in, it's the first rapid review group we've set up. People will recall we did it because winter was upon us. And so talking about the winter plan in March was not a tremendous idea. And I'm extraordinarily grateful to the members who were involved. And I understand the meeting you had was extremely productive. Councillor Daunton, then Councillor Costello. Councillor Daunton.
Yes, it was very productive. I think Councillor Costello and I were talking about it just before lunch. I mean, it was really quite a privilege actually to have that much time with the 2 senior people, and they answered all our questions. They came very well prepared. And I think that we felt that we got a good deal of information from them. And I think that there were things that we wanted, there were things that they were wanting to raise with us that we hadn't thought of, so that was really good. And particularly of all the items here mentioned, I think the role of the community pharmacies, I think that we picked up on that ourselves and how that had been working well, but also the fact that there was a shortage of pharmacists and how they were planning for shortages in pharmacies, and they themselves had been, I think what was helpful was to see how they had what they called, I think it was a gold team that had been very active during the pandemic, how they were building on that arrangement, the pandemic arrangement, and taking that forward. That was also very interesting. And then we ourselves spoke about the booklet, I think it's mentioned here, isn't it? And how that was, it was a really comprehensive piece of work on the part of the county and the NHS working together, and how we and they working together could get that out more widely, because it was really good information there, presented really well. I think that's.
Can I invite Councillor Costello to add to that, please?
Yeah, I can't really add anything to that. You've done really well there. The only thing I would say that I'm quite interested in, have we had any figures about bed blocking? Because normally, you know, December, January, February is the worst time of the year, and this was what this was all about, really. And I haven't heard anything through the local press, so I'm just wondering if it was easier this year. I don't know.
So I'll just give Patrick some thinking time, because and I think the question is, has hospital discharge come up with some issues because of winter pressures? Are you happy to answer that? Yes, you are. Thanks.
Yeah, thank you, Chair. And it surprisingly, and again, all the winter plans went in as usual, and you'll have heard that through the rapid review. But we're very fortunate that we haven't seen some of the pressures around the hospital discharges. That doesn't mean to say the hospital haven't been under significant pressures, but the hospital discharges that we would normally, from an adult social care perspective, be involved in, we haven't seen that level of pressures this year. We're not sure why, and it would be useful to do as part of kind of a lessons learned to understand that. We certainly did a lot of work around our preparation for it. I do think that going back to the earlier committee's discussion, I do think some of our work with the market, the recruitment, in overseas and international recruitment into the domiciliary market has created much more capacity there. And some of our intermediate care routes through reablement has meant that flows out of hospital through those pathways has been much slicker, because we've been able to source care. So it's moved people through the system. Doesn't mean to say there hasn't been people waiting and been delayed, but certainly not to the numbers that we were predicting and have we've seen in previous winters.
Okay, do any of the other members want to put any points in response to the report? Yeah, to put on record our thanks for doing it. I echo that totally. And I'm seeing nods everywhere, so that's the agreed outcome of that debate. We move to the health scrutiny work plan, pages 255 to 258. Rashenda?
Thank you, Chair. Obviously, it's quite scant, the work plan that's included in the published papers, but as the Chair mentioned previously, there is a work programming meeting next week for committee members to look at the scrutiny programme for 2024-25.
And just to add, thank you, Rashenda, just to add to that, so one of the outcomes of the review of health scrutiny that took place a year ago is that we should be more strategic in determining our programme and priorities for scrutiny. And so rather than just have a little catch-all at the end of the meeting and people throw out ideas, we're having a special meeting next week. We've actually got quite a few ideas already on the stocks, which Rashenda will bring to that meeting. But I invite all members to get your thinking caps on as well about what you think the priorities should be for health scrutiny, and then we can have a decent discussion next Wednesday at 4, isn't it? Is that right? Yes, it is. Someone said 4 o'clock. It is 4 o'clock. Councillor Slatter has seen that. And also, I know we're all busy, but can I appeal to all members of the committee to come to that if you possibly can, so we have a good turnout at that meeting, including our cooperative members. Please do 4 o'clock next Wednesday, all on Teams. You don't have to go anywhere. You just have to be free for a maximum of an hour. And with that, can we note the report? We have item 16, do we, Rashenda? Which you're going to kindly introduce at pages 259 to 266.
Yeah, thank you. Very briefly, Chair. Again, one of the changes we've introduced is the new health scrutiny recommendations tracker, just to make sure that the committee has oversight of all those recommendations and that nothing gets lost. So that's there for your information.
And very helpful, I should say. And so I'm glad I didn't overlook it. even though it's the end of the meeting. Does anyone want to make any comment on that tracker? No, but it's an excellent innovation, and thank you very much for doing it. The next meeting of the committee is on June the 27th, and we'll come back to you very quickly by email if we're going to use the reserve day on April the 25th. What I would say to all the officers who've been attending and presenting today, thank you very, very much. Or you pass that to all your colleagues who are not necessarily in the room at this second. To all the members, I think we've had an extraordinarily productive day. For me, I've enjoyed being back, I have to say, but I'm exhausted, and probably you are, and so it's a good time to say thank you very much and to close the meeting. Thanks.